Good afternoon. The April 13th, 2021 Board Workshop is now in session. Today we will have a health insurance update provided by Dr. Beth Fetty, Deputy Superintendent and Chief Human Resources Officer. Following this update, we will have discussion of the drug-free workplace policy facilitated by our General Counsel, Paul Gibbs. Ms. Escobar, roll call, please.
Mrs. Belford?
Present.
Ms. McDougall?
Present.
Mrs. Jenkins?
Present.
Mr. Susan?
Present.
And Mrs. Campbell?
Present.
We will now say the Pledge of Allegiance. All right, Dr. Fetty.
Thank you, Ms. Belford, board members, Dr. Mullins. Thank you for the opportunity today to present all things healthcare. We have with us our locked-in team, our consultants for our healthcare and our healthcare administration program, and they are going to take care of the lion's share of the presentation, but I wanted to introduce you to some key members. We have Mike Meredith. He's sitting. Would you wave, please, Mike? Mr. Meredith is the president. We've got Eric Torgy. He is the vice president. And then we've got Debbie Poole, and Debbie Poole is our account executive with Lockton. And Debbie is going to take over and start our presentation. We'll start with some things about Lockton, and then some plans, and then we'll move into some actuarial pieces. If we could, so that we can get through the presentation and make sure that all of your questions are answered, if you could keep a record of your questions, and we will have a question and answer session as soon as we're finished. So thank you. At this time, Debbie, it's all yours.
Thank you, Dr. Fetty. Just want to make sure everybody can hear me. So it's our pleasure to come today in front of the board. We have our agenda as far as what we're going to discuss today. We'd like to introduce you again to our team. We'd like to go through our 2022 marketing initiatives, some of the things we've already gone through with the school district with respect to procuring new benefit programs. We have a locked-in service overview that we'd like to share with you and some of the value-added benefits that we can provide to the school district, specifically with our InfoLog population health analysis overview. So we're going to go through that in detail and talk about how we can share data with you in a way that you all have not been able to see that in the past. We're going to go through our 2022 plannings and the things that we have in store for next calendar year, and we have an actuarial services overview to end it. So first off, Dr. Fetty introduced us, me and Mike and Eric. We have, within our overview, we have a number of strategic tools that we provide to Brevard schools, including strategic planning, implementation, benefit design, benchmarking. All the things that you see here on the screen are provided by your dedicated team. So in addition to the three of us, you also have Dennis Delaney. He is your dedicated actuary. We also have Lauren LaFawn as your account manager and Amanda Ismaili as the account analyst. Lauren and Amanda are very close and will work very closely with the school district as it comes closer to implementation and putting in plans when communicating to your employees. So our objective today really is to present our capabilities to Brevard Public Schools. We'd like to report our recommended procurement activities and our progress on all of those activities. And lastly, provide a financial update of current and future projected healthcare plan costs. So just starting out, we have a number of service contracts and insured contracts that are terminating at the end of this calendar year. Your plan year runs from January through December 31st each year. And so most of these vendor contracts are expiring at the end of this plan year. So our procurement plan, first starting with the benefit management system, this one actually expires in the middle of this year. The recommendation is to extend the existing contract for 12 months so that we can allow proper time to procure an appropriate and best-in-market benefit administration system. There are a number of components that go into the implementation of a ben admin system, and with the timeline that we have with implementation that they would have to go live in the next 60 days, it makes more sense to wait that out so that we can start the actual RFP process in July, map it out, decide what we really want to see in a new system, go out to market, get the best-in-class service, get the best-in-class product, and then have the locked-in HR tech team help by implementing that said implementation, that ben admin system. And so the intent of having a go live in mid-cycle, make sure that you're up and running and file feeds are in place. So by the time you go through open enrollment, it's seamless to the employees. So that is the recommendation, the existing contract just to be extended for an existing 12 months and not to go farther than that. And then again, start our RFP process shortly into the summer months so that we can procure a new system. Next is our dental insurance. So we have an RFP already open and on the street. We are asking for self-insured and fully insured proposals from the marketplace. If the school district chooses to select a self-insured dental plan, the dental HMO plan is not available on a self-insured basis. So if the district chooses to carry a self-insured PPO dental plan and maintain the dental HMO, the DHMO as it's called, you have two options on the DHMO, those two plans would have to remain fully insured, and the two PPO plans could could become a self-insured plan. So we have that RFP on the street right now. Those responses are due at the end of the month, and the evaluation committee meeting is scheduled for middle of May to go through those responses. Our vision insurance with Humana will expire at the end of this year, and so instead of going through the procurement department within the district, Lockton is taking on that marketing project internally. We intend to go to the partners of Brevard into the marketplace and look for bundled discounts, things that might add administrative ease like a single file feed, and certainly the most competitive pricing. So we are doing that marketing inside Lockton. Same thing with your life insurance, your voluntary accidental death and dismemberment, and your supplemental life insurance. Those contracts also expire at the end of this year. They're currently with Securian, actually expecting that renewal. Just got an email from him this morning by next week. So we'll take that renewal, but bump it up again against some of the other marketplace available best fit for Brevard Public Schools. Again, whether that's in a bundled discount or with a single EDI file, something that is administratively less disruptive to make sure you're getting best-in-class service, plan design, and pricing. Employee Assistance Program today is through Health Advocate. That also expires at the end of this year. We are looking at, we're negotiating the Health Advocate and also, again, looking to the marketplace inside Lockton for a market check on your EAP plan. Flexible Spending Account, Retiree Billing, and COBRA administration is currently being administered by Task. We have an open RFP through the Procurement Department today. Those responses are due at the beginning of next month. The evaluation committee meeting is already scheduled for those lines of coverage. So those actually aren't insured lines, those are service items. So separately, Flexible Spending Account, separately COBRA, separately retiree billing. Those are three separate functions. All three are currently being performed by Task. So the marketing objective is to make sure that we have the best in market, not only in pricing, but in the services available from the administrators in the marketplace. Today, your voluntary products you have with AFLAC. You have an accident plan, a critical illness, you have a hospital indemnity, and you have a cancer policy. Today, those benefits are run through an independent agent through AFLAC, and employees are asked to contact AFLAC directly to drop those coverages. They can enroll in those coverages through open enrollment, but throughout the year, they are asked to contact an AFLAC agent, and they have that face-to-face enrollment with the AFLAC agent. That's part of the AFLAC option today. We have an RFP on the street through the procurement department right now, so the voluntary benefit is out to market today. We are asking for same plans. We have better or same accident, critical illness, and hospital indemnity. We are asking for a flat commission within those plans of 20% for your voluntary benefits. In that commission, we will reallocate that back to the district in some way, whether it's by offsetting fees for your future Ben admin, offsetting locked-in fees for your HR technology support as we help you procure a new benefit administration system and implement that system, or actually offset our own fees. And so at the end of the day, all of those commissions that will be included in the voluntary products are going to come back to the school district in the way of offsetting future fees. Your current on-site medical provider, your on-site clinics are with Marathon Health. We are in the process of negotiating that renewal. They are looking at additional services within the renewal, so we are very close to having that prepared and ready to present. If it is at the discretion of the district. If you want to continue with Marathon Health based on the analysis that we're able to show, we'll be able to help with financially justifying the savings that they have already presented to the school and make sure that you're truly getting the best in class service with your Marathon Health on-site provider. Your stop loss currently is with Cigna, so that is probably the last thing that we're going to look at this year with respect to going out to market, just because it's the timing. We want to make sure that we have a firm stop loss quote towards the end of the year, because it's somewhat of a commodity and it's behind the scenes of the employees. That doesn't necessarily disrupt what's in your enrollment guide. We can finalize that in October and November. And then lastly, the medical ASO and the PBM. The initial contract had a 3-year agreement with 2 annual renewals. So it is set to expire at the end of next year for the RX. So we've been asked to go out to market and take a look at ASO and PBM marketplace at the end of this calendar year for 2023, specifically looking at PBM and ASO. We, of course, include your incumbent in that marketing, and it'll certainly go through your procurement department. So I thought we would add a timeline to help understand the lead time that we need to prepare for open enrollment. So we actually began working on these ancillary RFPs in February to build them out so that they could be posted at the beginning of March. The dental RFP posted at the beginning of March, as did the FSA COBRA and retiree billing. The worksite benefits RFP also posted the middle of last month. And in March, we presented to the SIAC committee with our 2022 projection. In April, we plan to do the analysis for the dental, the FSA, the COBRA, and the retiree, and the voluntary worksite. We anticipate your union negotiations will take place during the same time in April, and Lockton will be there and attending and presenting at both of the SIAC subcommittee meetings at the end of this month. So we have a data subcommittee and we have an education communications subcommittee that we'll be presenting to at the end of this month. Next month, we'll be scheduling the evaluation committee meetings with the evaluation committees that have been established and coordinated through your own procurement department. Our locked-in RFP for the Vision Basic Life and EAP will be complete by that time. We will have negotiated the Marathon contract by May, and we will have already started our negotiation for the ASO and the PBM renewal for January 1st, 2022, as we're already working through. We will be able to provide a final projection for the 2022 medical plans and contribution analysis, and we will present those things again to the SIAC at the end of May. Understanding that nuances of the district and the timing, if additional meetings are necessary between the time that we're able to provide that final renewal projection, and we have to continue to pull those levers and meet more often than what we're scheduled here to just come back in June, we're certainly happy to do so. But in June, we anticipate we would need a board vote for all the recommended renewals. We would go through implementation of the awarded benefit programs, whether it's with a new carrier or with your incumbent after winning the procurement bid. We will present to 2 separate SIAP subcommittees again at the end of June. Also in June, we will have your InfoLock data, which we're going to get to in a minute. We'll have all of your InfoLock data into our system in June. We'll be able to bring that back to you in not only with your quarterly pharmacy audit, which was included in our scope of service, but we'll be able to bring that InfoLock data analytics reporting to you as early as June. We also anticipate we will begin doing the benefit administration RFP at that time to help develop those specifications for what you need in a Ben admin assistant and build those requirements based on the board vote to do so. In July, we'll need to be in motion for open enrollment by developing and finalizing all of our open enrollment materials. We'll need to develop our enrollment communication strategy, which we expect will come out of the SIAC Education and Communication Committee. They've been working well together to work through that strategy. We will have the benefit administration RFP posted because we will have been working on it in June, and we have another SIAC committee meeting in July that we will present to. And then by August, we'll need to be in print with our open enrollment materials and preparing for early September distribution to all of your locations and your addresses. We'll be launching all of our open enrollment communications and making sure that repetition continues so we get good participation. We'll need to conduct the eligibility file testing. If we do change carriers and we have a new, one of the new carriers based on all the procurement activities we have, we'll want to make sure that eligibility file testing is up and running by August so that by the time you remit your actual open enrollment elections, you'll have no issues with the new carrier. We also start our retiree open enrollment planning, and the meetings begin in August. And back again in August, at the end of August, Lockton will return and meet again with the SIAC subcommittee meetings. So from a service overview, we really wanted to hone in on our specialty practices. So our health risk solutions team, they are the ones who are going to be bringing us the InfoLock data. So they can go through the best part about our InfoLock data is we get your claims data from multiple resources. So we've already established a claim file from Cigna. We're getting claims information now. We're scheduled to get the Marathon Health beginning May 1st. So once we have the claims system, claims information from Cigna, the claims information from Marathon Health, we can marry that information. Try to not talk with my hands. Step back. We marry that we love data. I'm sorry, I get very excited about this. So when we marry that data and we're able to bring it to you, it fills the gaps for what you haven't been able to see. So the canned reports, the information that you have typically received from your provider partners, you're going to see it in a whole new light by seeing it divided by, sliced by area, gender, age groups, specific conditions. If you want to see how many diabetics had a primary care physician annual exam, we'll be able to narrow down and actually see all that data, identifying those gaps in care, seeing the value within Marathon Health, bouncing the Marathon Health claims against what you might have spent if they went through the plan, taking a look at the discount and the savings that you're truly getting from that new silver plan against what might have come against the gold. So we'll be able to see a lot of that data and be able to really hone in on and identify ways to make a true impact on your plan costs. So that's our Health Risk Solutions team. They do that clinical claims data in addition to the Marathon Health data integration. And then they start to identify certain point solutions that make the most sense for your program. So if you have a high number of diabetics, of course, a diabetic management program makes sense. But if you didn't have a high number of diabetics, then that might not be the best solution for you. Perhaps you need to focus on another area. And so that's the beauty of having a multitude of data where we can, based on data, implement certain programs that we know are truly going to be able to have a value and an impact on the bottom line. Once we make that recommendation through our InfoLock data and we implement those things, it's the measuring that comes back around that makes the most sense. So we start with the data. Number one, we assess what is going on with your population. That means looking at medical and pharmacy claims, looking at your biometric screenings, the cultural assessment by area of the county, are you sicker or weller? The engagement surveys, all of these things that we do as an assessment, we look at your health risk assessments. All of that information, we then turn that into a plan. So that turns into your strategic development. So we look at a short-term and long-term goals. We want to make sure that we have that annual plan and looking into the future. Again, we always base that on our SMART goals. Then we go through implementation. So is that targeting access to care, well-being solutions, whatever we've implemented or set out to do in that strategy. We sit and we implement and we execute on that plan, and then at the end we evaluate it. So did it work? Did it save what we thought it was going to do? Did it engage your population like the way we expected it to? And that measurement, then we adjust and we start over again. And so it's an ever-changing and evolving process to make sure that we're always staying on target because your population is going to change. When we look at drug costs, and we've had a number of conversations about this in the SIAC as we've implemented the Save on SP targeting specialty drugs, that's what this slide is about. When we look at utilization versus spend, 85% of your population, 85% of your utilization is in that generic. Only 2% of your population is actually taking a specialty medication. However, 50% of your pharmacy spend is on those specialty medications. So 50% of your costs are only going towards 2% of your population. So when we look at making pharmacy solutions, they're very targeted. What is that 2% taking? How can we identify that 2% and hit that 2% target and drop that cost? And we'll be able to do that with data. More data info lock. So before I get into the group plan strategy, we at Lockton have what's called an ideal survey. What we like to do is we like to ask each leader of an organization to take the ideal survey that gives us an idea of your philosophy on benefit program altogether. Is it your, depending on how you feel about budget, is it about your employees, is it about loyalty, is it about cost savings? There are a number of different questions. It's a short survey, but if we would like each of you to take that ideal survey, we'll collect that information and it'll help us build what we call a group plan strategy. In our group plan strategy, we take your input from the surveys that you have taken, we take the information that we have in your claims, we take our big data, and what we do is we lay out a group plan strategy highlighting specific tactics that make the most sense for your business objectives and your benefit objectives. So when we lay that group plan strategy out, we start to identify those current benefit plans, details, and objectives. Then we select those tactics, and then we use that GPS to facilitate that interactive discussion. And so each time we come back to you, we can say, whether it's red, green, or yellow, that indicates employee friction and specific cost savings. So anything that's in the green, low friction, typically, high cost savings, or low cost savings. That's really where the 4 quadrants run. Whether it's low and low, high and high, we'll be able to identify what makes the most sense from the district based on your data and your input. And so we use that group plan strategy with a number of our clients, and it's shown proven to reduce the impact of trend by making data-driven decisions with your population and your data. We take not just your data, but big metadata as well. So when we look at how you compare to norm, that's also very important. Is that high? Is that low? How do we put a value on that? So we include our big data, incorporate that into your BPS data. We have that all through the InfoLock system that provides you with that insight. And so we are able to use InfoLock to identify key medical conditions, look deeper into your high-cost claimants, identify utilization patterns that maybe we hadn't seen in the past, certainly identify gaps in care, which I mentioned, and then stratify your risks so that we can target certain communication programs and certain cost-saving strategies to those specific populations. So again, just more information of what we learned from InfoLock. We take those insights and we look at cost, your utilization, pharmacy, your population health, and condition specific. So once we see something in InfoLock pop up, if it's diabetes, we may drill down deeper into diabetes and find out what is it. Is it the comorbidity of a diabetes, or is it medical or medication adherence? Is it not seeing a primary care physician? What is it? So we can drill down into that. And then we can take some actions. So is the action that we need to take plan design, or is it a carrier strategy? Do we need to change in that? We can have a network disruption analysis and take a look at what your network savings is. From the employer standpoint, is there something that we can take action from through communication or health promotion campaigns? Looking at third-party vendors for carve-outs and clinical solutions for looking into your specific clinical data, whether that's centers of excellence, on-site clinical programs. You already have on-site clinics. Does it make sense to broaden those and lean on your on-site clinics more? We'll be able to, again, have that action through the inside of InfoLock. So what have we been doing since January? We were here at the board vote on January the 19th, and we were so pleased to be awarded the business of being your broker, consultant, and certainly trusted advisor. Since then, we have hit the ground running with a number of different activities. And from a financial category, we updated your 2021 projection, outlining a couple things that were looked over from the last year. We also have updated your 2022, 23, and 24 future projections based on somewhat of a status quo. We have recalculated your 11208 valuation funding and come up with a number of different illustrations that could help to write the financials of your plan. We've also done some plan design and contribution analysis, certainly just the tip of the iceberg, but we have begun that activity. From a marketing perspective, as I mentioned, we've already built out the RFPs for the dental, the voluntary worksite, FSA, vision, Basic Life, and the EAP. From a compliance support, you may remember Mark Holloway from our finalist meeting. So he is our ERISA attorney with a sense of humor, and he has been readily available and accessible for a number of different compliance issues. We always have the webcast and the podcast, and I know the members of the Risk Management and Benefits Department are watching those, but he's also been able to provide helpful insight onto your 11208 valuation. We're doing your document review and giving us additional HIPAA and Section 125 guidance, so he is certainly a valuable add to the locked-in team. For SIAC and the school board, we have presented to the two subcommittee meetings in February. We presented to the SIAC. Last month, we presented updated budget projections, benchmarking from local school districts, and also some cost mitigation strategies, and of course, our board workshop today. Our Pharmacy Solutions team is already working diligently on your PBM contract. They're reviewing the contract today. They're negotiating some mid-year changes and potential cost improvements. We have an upcoming audit and review that, as I mentioned, we'll be bringing that quarterly pharmacy review to you all in June. And then lastly and not least is our population health. Your dedicated population health consultant is already working on the Marathon Health contract review and renewal negotiation, doing the analysis on some early point solutions, including Surgeries Plus and Hinge Health, which we're going to talk about in a minute. And of course, she will be presenting our InfoLock data collection. As I mentioned, our Pharmacy Solutions, they are reconciling Cigna's internal audit and looking at rebate discounts and the performance discounts that were delivered based on Cigna's response. And then we're going to provide that quarterly pharmacy review next month. The next thing I want to talk about is Surgery Plus. This is something that we had talked through with our Point Solutions, Health Risk Solutions consultant, as far as a mid-year impact that can be made to your medical plan. So Surgery Plus is a bolt-on additional program that can be implemented off-cycle that specifically targets the appropriateness of care and the affordability and access to care specifically for covered surgeries. And so the intent of Surgery Plus is to reduce the total cost that's impacting the plan through elective surgery, and I don't mean voluntary, non-medically necessary surgery. I'm talking about a knee replacement where you time it, or any kind of joint type of surgery where you time it. Nothing that is an emergency type surgery. So those are the types of surgeries that they target. The intent behind Surgery Plus is to make sure that the patient has some concierge care if they are a candidate for surgery. They are directed to the most appropriate point of care, and the appropriate point of care, not only is that less expensive, but they have better outcomes. So again, in the case of a knee replacement, they would direct that patient to a physician and a facility that has done 1,000 knee replacements instead of a facility and a physician who's done 4, just because of the proven outcomes of that particular provider. And then again, with the affordability, because they have that negotiated contract with those directed facilities, the cost back to the plan is considerably lower. And if you have incentives set through the member in your plan, it can have significantly lower costs to the member as well. So on this page is all of the most common treatments served by Surgery Plus. So if you just want to take a look at that. I'm not going to read this to you, but we did provide Surgery Plus with some of your claims information, including some of the costs of care in the freestanding facilities, because we know that measures have already been made to save money on the plan by directing employees to those freestanding facilities for some of these types of treatments through a small copayment versus coinsurance and deductible. And so even comparing what the district is paying today on those freestanding facilities, we still believe that there will be some cost savings through Surgery Plus. This is a case study with another client that actually does cover bariatric surgery. Your plan does not. In this case study, we started with an incentive-based design, waiving the deductible and coinsurance for anyone that was having one of those covered surgeries. And in that incentive, we were able to get 548 open cases and 155 completed procedures. And at the end of that year, it was a $1.2 million savings at a 12-month period. So because it's impacting those surgeries that the patient is actually thinking through, they're able to catch them early enough so that they can make an impact on the effectiveness on the surgery and as well as the cost.
If I could, this particular case study is on an employer group that has almost an identical size to Brevard Public Schools. So I think it's a good example of what's potential.
Agreed. The next thing I want to talk about is Hinge Health. Hinge Health is a program specifically designed for musculoskeletal surgery avoidance. So if that person who thinks they need a knee replacement is engaged with Hinge Health, they target members who are suffering from chronic pain and considering surgery. They voluntarily enroll, so it's completely voluntary to the member, and they do a little bit of screening to make sure that they're a proper candidate for the physical therapy, which is the alternative to surgery. So it's a 12-week program. They are meeting with a health coach virtually who is also supported by a physical therapist. They get a tablet and a wearable device. So in the case of a knee, it's something that goes over the knee. In the case of the shoulder, it's something that goes over the shoulder. It talks to the device, and it tells whether or not you're doing your exercises properly, and it gives immediate feedback. That tablet immediately talks back and forth to the Hinge Health health coach, and you can have that dialogue. If at the end of that 12-week program you haven't shown enough improvement and you're still a surgery candidate, Hinge Health can then redirect back to appropriate care, and if Surgery Plus is in place, Hinge Health will direct directly to Surgery Plus. So you have that double solution for the same problem, and a solution for your employee that should get them back to work sooner. So in the way the pricing is set up with Hinge Health, you'll only pay for it when they use the service. And so you're not having a line item in your budget. You're only using it when they're engaged in the program. And Hinge Health is already looking at a 3-to-1 ROI, sometimes as high as 5, based on what you're spending for the program and what you've saved by avoiding that surgery. And so by looking at that program in whole, they are looking at that 1-to-1 ROI the first year, but really looking at a 5-year closer to 3-to-1. Included with your locked-in scope of service is a clinical review of your top 5 largest claimants in our year 1. Next year there will be more, but this year we are looking at 5 large claimants. We are already engaged and looking at a newly emergent large claim today. That clinical review is going to look at the claim detail to identify any opportunities to validate the cost, whether it's the treatment, the diagnosis, overcharging, double billing, things like that. They do that through an academic partnership with the hospital, with the peer-to-peer through the medical plan, depending on the situation and what comes up. And then, of course, they develop an action plan to make sure that those savings are returned back to the plan. And never with an impact to the member. Usually it's something that they find, it's the $10,000 toothbrush, right? So that's what they find. Okay. So from an actuarial standpoint, some of this information was presented to the SIAC committee last month. What we did is we took a look going back in time and looking at your total overall spend on your medical plan to see what the actual trend is. So what is the Brevard actual trend? Because there's a national trend out there, but we want to make sure that our projections are looking a little bit closer to your trend. So we go back 5 years. On the left, just looking at the chart, the year is on the left-hand side. The next column is your total paid claims before being reimbursed and reinsured by your stop-loss carrier. The next column is the actual reimbursement you received for those large claims, netting out your claims in that 4th column. Your gross per member per month cost has gone up each year. And in 2020, that trend was up by 11.2 from the year prior. The net per member per month trend, or the cost, is $525.66 in the year 2020. That trend is 9.3 just from one year to the next. But we never look at 1 year. We like to average it over 5. And so from 2016 to 2020, the average trend for Brevard has been 6.8 gross or 6.3 net. Now we typically use, Locked-In typically uses a trend in between 5.5% and 7.5%. So you're right there in the middle, okay? We also look at your large claims history. And so your large claims analysis shows that you had a real blip on the radar last year in 2020. You had an extraordinarily large number of high claimants. And when we say high claimants, this is specifically focused on claims that are over $50,000. Highlighted in yellow is your stop loss threshold. So anything above $450,000 from an individual is reinsured by your stop loss carrier. But every other claim that's $449,999, that's all borne on the district dollars. So when we read this chart from top to bottom, let's start with the norms. So when we talk about locked-in norm, the norm is to see 226 claimants over 50,000. Of that, 86 might be over 100,000. Of those 86, 27 are over 200,000, and so forth. When we look at Brevard's claim experience in 2020, you had 266 claimants over 50,000. Of those 266, 109 were over 100,000. Of those 109, 32 were over 200,000. Of those 32, 15 were over 300,000. And you had 8 claimants that hit that stop loss threshold of 450,000. Compared to the year prior, you had 2. The year before that, you had 5. And our norm is about 5. So again, an extraordinarily high number of large claimants in your 2020 plan year. We also look at the average paid per claimant. And so the average paid by the norm, we normally see claimants that exceed 450,000. We normally see them about $734,000. In your case, the average was $684,000, but you had 8 of them. Not 5, not 2. In 2019, the average claim was closer to our norm at $741,000, but you only had 2. Same thing in 2018, much lower than the norm, and you had our norm of 5. So again, 2020 was a tough year for you all with large claimant, with nearly 1.7 million reinsured for claims in excess of the stop loss. So when we do a budget forecast, the reason I went back through the trend and the large claimants, both of those things make a big impact when we project your costs. So in the spirit of giving options, we have 3 different ways of calculating our projection. In scenario 1, we're using the locked-in standard trend of 5.5% on medical, 10% on the RX, and assuming the current 8 high-cost claimants. Scenario 2, a little bit less conservative, still using locked-in's trend, but we're going to regress back to the norm of 5.2 high-cost claimants, but still keep the locked-in standard trend. Scenario 3 is probably the least conservative because it's using BPS's actual trend of 5.5 on medical, 9 on the RX, and again, regressing back to the norm of 5.2 high-cost claimants. And so in those scenarios, we built out an idea of what that would create from a shortfall perspective. And the reason we added Aon to the slide is because we wanted you to understand the difference from where we came, and we explain this through the SIAC, and it's in the footnote here, with respect to using different months and the shortfall of the calculated expenses. So what we're seeing in scenario 2, scenario 3, the least conservative, by the middle of this year, when you need to file your 11208, we're projecting a $5.2 million shortfall in scenario 2 or 4.8 in scenario 3. If we carry that forward to the end of the plan year without additional funding, that grows to 11.7 million by the end of this year and 10.9 in scenario 3. This is just the 2021. 2022, again, assumes nothing happens, no additional money comes into the plan, no changes are made, everything's status quo. Again, in scenario 2, scenario 3, by the time you file next year's 11208, it's at 13 million versus $11 million shortfall in scenario 3. So we've talked through different ways of doing the projection. But at the end of the day, even in every scenario, we do have a shortfall that we need to manage. In the spirit of full transparency, we wanted to show you how we arrived to the budget forecast for scenario 2. So on the first row, we have your rolling 12 months claim. We have medical and RX separated. The large claim adjustment for scenario 2 is assuming the regression back to 5.2 large claimants. The trend, again, is assuming the 5.5 and the 10 on the RX, which is the locked-in trend. The trend factor is trending forward for the number of months that we're looking at, because we're not looking at 6 months, we're actually looking at, oh no, this one is actually looking at 6 months. We have that ahead of us. And then we have the save on RX, which we do see here as a 0.96. That's a 4% impact. We do see that coming in. We're projecting and accounting for that in our projection for 2022. We take our claims projection and we add in your fixed costs, which include your administrative fees, your stop-loss fees, and the clinic expenses, and offset by the expected rebates. We still see a predicted shortfall by the end, an increase is what we're expecting of $9.3 million, more than what the plan is costing today, which is about a 13.5% increase. So again, understanding the gravity of filing for the 11208, we did look at a number of different infusion scenarios. This is one of, I think we've gone through 8 or 9 now, just to understand what's the best way to put money into the plan, budget for the future, what makes the most sense. Can we have a recurring infusion? Do we need a single infusion? That would be something that the board and the superintendent will manage. This is simply an illustration forecasting what it would look like to have a non-recurring infusion, 2 of those done by the end of this year, and then recurring infusions next year. We modeled just 2 options for plan design changes. You can see here the projected savings from these plan design changes aren't going to move the needle a whole lot on a $5 or $6 million shortfall. So we want to be cautious about the plan design changes that we do make so that we have those that have the biggest bang for the buck. And then the cost share currently today, just to remind the board where cost share is today, you have a gold plan, you have a silver plan. And each one of those, the employee contribution is in blue, the BPS contribution is in gray. The employee is paying today 21% of that premium for employee-only coverage in the gold and only 17% under the silver. Also giving a subsidy to the family. So today, the board is subsidizing 66% to the families and 69% for the silver plan. So you see that as well in your current cost share. If we were to take the scenario 2 as it is on the page at a straight 13.4% increase and looked at that from a contribution increase, again, just an illustration of what does 13.4% look like on a month-to-month. We've calculated that for the gold and silver plan as a monthly increase. The new contribution is bolded in blue. The amount of increase is italicized in blue. From an annual standpoint, on the far right, we show what that annual impact would be to the employee in each one of those family tiers in an increased premium. So in this scenario, again, if we're increasing by both employer and employee by 13.4, the family tier in the gold plan increases the most. The total amount annually more is $1,047. So I will take questions and happy to back up to any slide that we like. I know that was a little fast, but want to make sure that we got through our materials and time to answer any questions that you may have.
Ms. Campbell, you look ready? That's okay.
All right, thank you for all of that. Much of that I got to hear on SIAC, and it was good to hear it again because even though I'm a numbers person, sometimes, it doesn't always sink in the first time. So just as going back to the page or slide 8 on the dental insurance, you're going to bring us the options, or RFP is going to bring us the options of self-insured versus fully insured. We are fully insured currently.
Correct.
With the optional dental insurance that we offer. Is that something that's usually beneficial to an entity to do the self-insurance on dental in particular?
Typically, the employers that we see who want to do self-insured dental are contributing towards the dental.
Okay.
And so there's a savings to the employer because those rates go down. In your case, the dental plan is 100% voluntary. However, if there's an opportunity to lower dental costs through a self-insured split option, because again, the dental PPO would be able to be self-insured, the dental HMO would continue to be fully insured. If we're able to reduce those rates through payroll dollars, then the employees will have more payroll dollars to be able to tolerate a medical plan increase. So there is some strategy around reducing your dental rates for sure. Having a self-insured dental plan would require, again, you'd have to file the 11208 that is still included in the state's requirement. So much like we track the performance of the medical plan and the deficit and the surplus and the rate setting, we would do all the same things for the dental plan for the self-insured PPO.
So it would be similar. You have to have the 2 month. It would be a separate fund.
Yes.
And it would have to have 2 months of dental.
Yes.
Okay, gotcha.
Yes.
All right,
Correct.
and then when we have the RFP review committees that you guys will be sitting on mostly in May, do you guys sit on that committee as well?
I
An
don't sit on
advisory
the
vote?
committee. It's my job to serve the district by
Right.
laying out
But you're
information
there.
in a reasonable way. We won't be making recommendation. It's really our job to help the committee understand the data that's been sent. So usually in an RFP, there's just a deluge of information. And so it's really our job to make that readable and understandable and help the evaluation committee deliberate and come to a reasonable decision.
Gotcha. Let's see. Not all my questions are related to this slide, so let me. On slide 25, this was on the slide. And pardon my ignorance of insurance terminology, even though I've been on SIAC for more than a year, but COE,
Center of Excellence.
thank you, and you had
You
said
bet.
that. And the difference between the blue and the green, all those are services that would be covered under Surgery Plus, correct?
Right, right.
Okay. And then,
With the exception of bariatric for GPO.
our plan does not
Sure.
offer bariatric, okay.
Mhm.
On the Surgery Plus, how does that, because I know we have a lot of other services, like concierge services and things like that. And the question is always, how do we connect our members, our employees and their their dependents with this? Who does the reaching out? Does Surgery Plus reach out, or Cigna, or whoever reach out and say, hey, we have a lower cost option for you, you really should do this? Or is it incumbent on the member to seek that out?
So Surgery Plus will provide a number of marketing materials to get the word out. We can use a number of different vehicles that the board already has in place, whether it's your website or through your Ben admin system or a number of other tools, Health Advocate, other ways that we can pump the message out to communicate that's available out there. Then we incentivize the members of the plan by saying, when you do this, it's not going to cost you anything because we're waiving deductible and coinsurance based on what we expect to save.
Wow.
So that's the carrot where we say, if you want to have your knee replacement done going through Surgery Plus, you'll not have to meet your deductible, you'll not have any coinsurance, so it would cost you nothing out of pocket, and it'll still save the plan.
Yeah,
Okay.
if I could, typically because the negotiated rates are on a bundled basis, as opposed to a discount, on average, they're about 25 to 30% lower than what you get on your Cigna discount. So by giving essentially the employee, you're still going to net, in the 20 to 25% range back to the plan. But the employee, it's actually, for those that we've implemented, we have a lot of employers that have already done this. It becomes an employee benefit that's very popular, but it also helps, the plan save money. So it's kind of a win-win.
And return to work, so you have better presenteeism and a slower, or longer, shorter rather, recovery period.
So-
And one other comment too, Surgery Plus, all of their contracted providers, if there is a redo on that surgery, it's on the provider. They have to basically do the redo at no additional cost. They don't have a lot of redos, quite frankly, because they only select the providers, the surgeons that are in the top quartile at doing that specific surgery. So unlike just using like an orthopedic surgery for a shoulder or hip, they literally go to the surgeons that's what they do. They only do hips, or they only do hands, or they only do shoulders. So it's much more specific, and that's why their outcomes are so much better.
Can I?
Yeah,
I have a question
yeah.
on this part too. I'm sorry, do you want to?
No, go right ahead.
So the providers in this network, are they local? Do they
Yes.
have to have a bar? I just,
Yeah,
They're local, and they may overlap with the providers that your employees are already seeing.
Yeah, we've actually done an analysis, and at the facilities, they're already contracted with 60% of the facilities currently being used. They actually looked at your claims data, and 60% of the people that are already going and having procedures done would have had that savings had they been gone, had this already been in place last year. And so the plan would have saved money, and then they would have had a lower cost to the employee. So the good news is that we've implemented this program. The state of Florida has this program, other clients. But you're one of the few exceptions where literally the majority of your employees are already going into those facilities. Going forward, if they were to have Surgery Plus, the plan would just pay less for it, that's all.
so
If that makes
Surgery
sense.
Plus, if I'm understanding, that is just, it's part of our plan, and we educate them. It's not something that they have to pick. It's something that we kind of help them know that it's out there. It's not a standalone thing. It's part of the whole benefit package.
Yes and no.
It is part of the whole benefits package, but just to like full transparency, it's outside of Cigna, for instance, okay? So in other words, basically, Surgery Plus, just like Cigna sends you like a listing of the procedures, you would write, essentially a separate wire transfer or whatever for the costs that fell into that bucket. But it would definitely be something that you'd want to incorporate into your whole health and welfare program, so it's seen as one of your benefits that you're offering at the district.
And so, your providers, I'm sorry, I have a lot of
Make sure
questions.
you get your mic.
Thank you, Katie. So the providers, how do I want to say this? I'm just going to say it. So do you rate your providers? I mean, are your providers, what if you have a provider that's on there that's not so good? I mean, how do you know that you are getting the top providers? Because I can see people saying, I like my guy. So how do you help that move to Surgery Plus? Because I think it sounds like a great idea.
Sure, and there's some information that we can share in a separate presentation. We'll be happy to share that with the board. But that being said, there are independent resources of information regarding outcomes for hospitals, for surgeons, for doctors. So this is all data-driven. It's not something that Surgery Plus is telling us, yeah, we got some better doctors. They actually use a couple outside sources to validate that they're going to, that the panel that they're providing are in that top quartile in terms of outcomes. Because they look at quality and outcomes, cost is secondarily. But they also realize if you do it right the first time, there's a lower cost even if there wasn't a discount.
I'll think of more, but go ahead, Matt.
I just want you to know that I've looked at this company before, and it was one of the things that I was trying to drum up. They only allow their, can I take this off for a second? Or do we have to learn? They only allow board-certified physicians, top line. And right now, they just got a letter back from the state. They do all the State Workers Association, and they had only 2 out of 300 surgeries, I think, or something like that, that came back with, that they had to go follow up. The average in our industry is like 1 out of 3 to 4. So it's significant returns on investment for their, and that's my biggest fear, was that our people were going to do that. Like, hey, why do I have to go down here? But when you look at the list of the doctors and the outcomes, they're the best of the best in the state. But I did want to piggyback on the bariatrics and stuff like that, because that was a conversation that we had, that we don't cover that, right? But what it does for our employees is what Mr. Meredith nailed on the head, is that if our people were going to have that surgery, this reduces the cost to them but significantly, on top of reducing the cost of all those other surgeries to our people. So this is a huge opportunity for our people. I had a question. We were talking about the how. Like, how do we let them know? Right now, if Cigna has a pharmacy that's on their home delivery, right? Cigna says, you have to go to this, right? Is there a way to create a funnel, Mr. Langdorf, where they, if they're going to have a surgery, that they have to call Cigna or whoever, and they say, just so you know, you have this available? Does that make sense to you? Rather than just, because we know the teachers, they don't have the opportunity to read their emails as much, but maybe an opportunity where we're notifying them before the surgery actually comes and takes place. Is that something we can do?
I think the initial approach we wanted to take to that was, I haven't seen the entire presentation of the savings yet. We're still waiting for that to come in. So that's something that they will be presenting to the SIAC at this meeting, or is it the next?
This month.
This meeting. So we're gonna present that to them then, and we will initially look at it from a voluntary perspective. That's one of the reasons why you can waive any fees, and employees will like being able to go to a surgery without any cost. So we believe that will be a good option for them. We can look at doing a required referral starting at a later time, possibly in January. And then they could not have a surgery without going through Surgery Plus first, or at least validating whether the surgery is done that way.
I was just, I understand and I understand completely what you're saying as far as making it voluntary, requiring, and everything else. What I was saying is, that's great in the future, but right now, when somebody goes, how do we, if we send out a couple of emails and we notify them in our normal notification system, portion of our schools and our teachers don't see that. So like all of the other things, like when I had a situation where I had my daughter's surgery in Orlando, I was given the opportunity. Cigna called me and said, hey, I want to let you know, these are your other options. Is that something that we can put into place so that when people are going to get a knee surgery or whatever it is, that they know that they have this option available to them as a last, does that, you guys
Yeah,
follow me?
so what we do to get Surgery Plus data is we give them that information. So we also have to give them who's enrolled in the medical plan, because this program would only be eligible for those that are enrolled in the medical plan. So we're already giving them that information. If you're asking if we can funnel targeted communication, Surgery Plus has a number of different materials and marketing campaigns that we can look at, and we're going to that's what we want to talk to the SIAC subcommittee about, is what's the best way to get the word out for those. Even there are still people that are suspicious of a phone call, of getting that phone call or a postcard in the mail, until maybe their friend said, oh, you know what, I just called them and it's not going to cost me anything. Word of mouth sometimes is more effective than a postcard or a phone call. So we want to kind of talk to the SIAC subcommittee and find out what their peers are feeling and what's the best way that the population will take a hold of this, and how can we get that message out before the end of the school year.
Right, and we do the communication between all of our employees and everything else. I get that, texts, mailers, all that stuff. But one of the most effective things that we've seen in the past is that when somebody is actually has and ready to take the surgery, they've been recommended, that they are then told at that moment that they are allowed to. Do we have anything that grabs that gatekeep and allows them at that moment to know the difference between the two?
I'd like to take that back and give you a better answer. Because
okay.
I'm not entirely sure what data
Beautiful.
we can get and what would trigger their outreach.
Well, I know like when Cigna gets that we're having a knee surgery or something, they're
That's
supposed
a prior authorization. Right?
There you go, prior authorization, they're supposed to. So if we can find somewhere in there that the conversation
Sure.
does, because I know a lot of our people are so busy right now that a lot of the opportunities to educate them on the different opportunities doesn't always happen. So
Sure.
in order for us to drive the significant cost savings, I think that if we put something like that in, our education in our school district is one of the things we've been trying to push to get people more educated so that they take advantage of these things, and I think that would help us.
I agree.
The other thing I was going to ask is that we wanted to try to get this in before the summer, because that's when everybody starts their surgeries. Are we on pace to make that happen?
June 1st.
Okay. And tell all of our people not to have their surgeries, because this might be good. I'm serious.
One of the comments, almost like Back to the Future, going back 20 plus years, I mean, it used to be that all plans had either like a second opinion mandatory or pre-authorization for surgery or hospitalization. So we probably also need to talk to Cigna and see if they could, as part of a pre-authorization process, provide some
Right.
information. That's the conversation. We can't obviously answer that at this point.
Perfect.
But Cigna does use the Evacor, their Evacor system. When something's been recommended, they will call those directly. If we can piggyback that into this, we'll certainly try to move in that direction.
Perfect.
If not, we'll look for another solution.
Yeah, thank you.
Sure.
And I'll reserve the rest of my stuff for later.
Ms. Campbell, I think we interrupted your line of questioning.
Yes, and I apologize.
No, that's okay. It's okay, because I mean, we're on there, there's no point in going back. I love these benefits that are benefiting our plan, obviously, but are a tremendous benefit to our employees. So with that thought, the Hinge Health thing, I just want to make sure I'm understanding that. That's something that's done at home rather than on site. So not only are they saving money, they're also saving drive time. So it's physical therapy at home with the little computer telling you you're doing it wrong, right? Okay.
The intent is to eliminate some of those barriers.
Okay,
And if
because
mobility
that
and
is
getting to those
so
places
important.
is, part of the problem,
Right.
we try to eliminate that with Hinge.
Can I follow that real quick?
Yeah.
So that is also, Surgery Plus also has that too. It's very innovative. You have where they can go on video, and Hinge Health is actually a part of Surgery Plus. They work together, but I do know that that's an amazing opportunity. Thank you so much for bringing these to us. You guys have been doing great.
That's been awesome. Okay, so my final question, Ms. Belford, is related on slide 33, thinking about the 3 scenarios and getting back to our fund balance. The differences between scenario 1 and one of the differences 1 and then 2 and 3 is the high cost claimants. Do we have, and this may be a Mark question, do we have any idea so far for 2021 how many high cost claimants we have?
I get emails periodically whenever we have a high-cost claimant. So I get those frequently throughout last year, a lot more than I have so far this year.
Right.
I can say that. We have had one claim that was pretty high price. We don't have that negotiated pricing down. Typically what happens, a provider will send a bill in, say for $1 million.
Right.
Cigna will go through their process and they will reduce that bill based on their contracted rates. So $1 million claim may come down to $600,000 or $500,000. Once we get that, that's when I get the notice. So I'll have an idea of where we are.
So it's a little early in
It's
the
a little
year
early.
to kind of see how we're trending so far this year.
I can say this, I haven't seen, other than one, I haven't seen any over our self-insured retention at this point.
I haven't either.
Yeah,
I get the
if
same email.
if I could comment, though, from a holistic perspective, because this early in the year, typically you wouldn't. In fact, if you track groups of this size, we typically see 50% of the cost being paid out in the last 90 days because they're accumulating
Right.
during the course of the year, and especially if they're auditing bills. I mean, there's a lot of things that go on behind the scenes that delay that. So I would say even by July 1st, we're not going to have an accurate picture. If we'd be closer to one October, November, but that's more holistically, not specific to BPS. But I think it's important to look at that because that's more actuarially credible in terms of a big picture.
Gotcha.
A claim might be open for a period of time, and so that's why that takes some time for the trailing billing to come in.
Right.
No, that makes sense. All right, that's all, Ms. Belford.
Thanks, Ms. Campbell. Ms. McDougall, did you have additional questions?
Just one related to
Whatever
the,
you, I'm not rushing you.
Ms. Campbell's covered much of what I was thinking, we were not along the same lines, but, okay, and this may be a goofy question. So what's in it for the doctors for Surgery Plus? Why would they want to be in that? No, I really want to know, because why not be not part of that? So what's in it for them?
Volume.
Okay, I think, well,
It's not up to the doctor.
right.
Surgery Plus chooses them because of their outcomes.
Okay.
And so it starts with them being selected. It's not, I'm going to sign here and, okay, Bob Jones can just be in the plan. It doesn't work that way. They're specifically looking at outcomes, and if their outcomes are good and then they're in the right geographical area, they'll do an outreach to negotiate specifically with that independent or practice, depending on the.
I would also,
I think what you're asking is what's the doctor's incentive?
Right,
When Surgery
exactly.
Plus comes to them, and the advantage is that they're looking at, for instance, let's talk about Brevard County right now. There's 40% of the pipe. So 60% of the facilities are in, that means 40% are out. And they're, let's face it, the more surgeries they perform, ultimately they'll make more money, even if they give a, discount on a unit basis. So they also get paid faster. There's several things built into their contract that actually make it, from a cash flow perspective, better for them. And they also get a higher volume. So they're basically saying, okay, I'm going to get a lot more of these things coming my way. So yeah, I won't make as much on each surgery, but I'll have more of them.
Thank you.
And less stress on the billing, because billing's been difficult for our providers.
Yeah. Ms. Jenkins, did you have any questions?
Yeah, I do. So with the Hinge Health, I see here that it's voluntary, but I just want to clarify. I know there's a couple of plans, I'm pretty sure this happens with Medicare as well, where these solutions to surgery avoidance are kind of mandated in a sense, given as an option before you're allowed to elect for that surgery. So I just want to clarify, this isn't something that would ever delay someone's surgery if they felt they didn't want to participate in it?
No, it's 100% voluntary. And again, they are really just trying to identify those that are a candidate for surgery but haven't tried anything else. And if they want to participate, they can. If they participate and, kind of participate, I'll kind of wear the device, they'll do the best they can in the 12 weeks, and then they'll refer them to Surgery Plus to go and get that surgery if they necessarily need it.
Well, interestingly enough, and this is, again, from the medical community speaking, because I've done a lot of reading, surgery is generally the last resort. Typically, and I have people in my family that can attest to this, but it's if they can have other types of treatments, rehabilitation, physical therapy, those kinds of things, that's even with Surgery Plus, before they actually have, as you pointed out, they actually have a written agreement now with Hinge Health. So they believe, even Surgery Plus, that the best route is alternative. But if they really need to be certain, and there's times when that's the only solution, the best solution, then they would definitely recommend that. And I can, speak personally, because my wife had a bad experience with spine surgery, and we went to a Surgery Plus top tier in Tampa, and interestingly enough, they read through all the the X-rays and MRI, all the information, and we went in hoping that he'd do a redo, and he's like, look, I'm not making any money by telling you this, but that's the worst thing you could do. Your mobility will actually be reduced, and you'll be in a bad way. So they're selecting physicians and surgeons that care about the outcomes, and their reputation is based on that. And I think that's important in terms of quality of life, because I know a lot of people have had surgery and now their quality of life is not good. So, there are times when that is the only and the best solution, but that's the goal. And I think the fact that they are aligned with Hinge Health sends a really positive message.
So I completely understand that, and I understand how sometimes less invasive is better, but I just want to clarify. So if the patient says themselves, that's not something I want to do, I want to have this surgery now, this isn't a stopgate for them?
Of course.
Right.
Okay.
Yeah.
And then just a specific question, but we've seen an increase in those large claims. And is it safe to assume, or do we have data to prove that this is due to COVID hospitalizations and ICU? Do we have any idea what that focus is?
Most of them are not related to COVID.
Okay, but we know exactly, okay,
We have the general diagnosis for all of those.
okay. Thank you.
Can I, just, Mrs. Jenkins, you sparked a question, just to clarify it. Is there any speculation that any cost increase in hospitalization and/or physician care has increased as a result of COVID, even if the care itself is not attributed to COVID? Does that make sense? Is it possible that expenses in 2020 were disproportionately higher just by virtue of us being in an environment of increased cost for medical care?
That's actually a great question. And actually our actuarial team we have a lot of data and information from across the country, and I won't speak specific to your data because it's not large enough to be credible. But I will tell you that we actually build in a factor, even in the projections, that take into consideration that during COVID, there's a lot of elective procedures that were not done, so you actually had a reduction in your cost as a result of that. And then we also build in a factor based on what we're actually seeing as far as COVID-related, and it's pretty close to a wash across the board. In fact, there's actually, most of our plans, our employer group plans are actually down because the COVID expenses have actually been less than the elective surgeries and other things that were not performed. And unfortunately, and this is what our biggest fear, is people not going in for their screenings and things like that that they should have been doing, which ultimately have an impact on long-term costs.
Right.
And we've tried to take that into consideration, but no one really knows, what's going to be the fallout of that. I mean, and not to try to be scared, because we really just don't know. And it may not be that big of a deal, but we are taking a very close look at it. So hopefully that answers your...
It just seems interesting to me that I think to your point, Brevard Public Schools Health Insurance Trust Fund theoretically had fewer claims against it by virtue of elective surgeries being reduced, yet clearly our expenses are much greater than they were the year before, which would imply that the services that were provided were at a greater cost. So I guess to oversimplify my question, is an appendectomy 40% more expensive in 2020 than it was in 2019, or is it marginally more expensive? Does that make sense?
No, I mean, it does make sense. I mean, and quite frankly, because you're contracted, with Cigna, and they already have pre-negotiated either bundled case rates or discounts. I mean, all of the hospital systems annually change their charge master, but we haven't seen, at least at this point, we haven't seen any evidence that they have artificially increased it above what their contracted rate is, because then they would be going outside of something they've already agreed to contractually. And I would think that all of the carriers will be all over that, because ultimately that's going to erode their discount.
Okay, thank you.
Anything else, Ms. Jenkins?
No, thank you.
Mr. Susan?
So I just wanted to say thank you for everything that you guys have done. I think you guys can see the difference between the improvement of consulting that we've had over what we had last year and the year before. I'm honored to have you guys part of our school system. You guys have been doing an amazing job from soup to nuts, and you guys have you're pounding through it. So thank you so much, and I really appreciate it. It's like a breath of fresh air when you start talking about it. One of the things that I saw that you guys had mentioned about is data and analytics and all of those things, and that's music to our ears, because one of the issues that we've been presented in the past was that wasn't there. You guys are getting complete access to all of the Cigna claims and everything else, putting them in the locker and evaluating them, and there's no hiccups or anything inside there, right?
No, that's correct. We're kind of data geeks. I mean, we don't make any recommendations or we don't make any decisions unless we have the data to back it up. And we're our whole team, our actual team. I mean, we do everything based on what we aggregate all of your data coming from Cigna, Marathon, any other sources. If we were to carve out the PBM, we're getting direct feeds on a monthly basis, and it's all going into one. You've never experienced that before, and having all in one place,
right,
where we can then analyze it and come back and say, oh, hey, here's some real gaps in care, or here's some things you ought to consider with your plan design based upon what we're seeing. And we feel like that's going to give you a lot more information to make prudent decisions.
And that's absolutely amazing. I really appreciate it. One of the questions I had is, and again, like if I'm asking questions that we need to come back to, just feel free to say exactly what you do, because I love when you said that's something I can go check on. And we appreciate that, because that hasn't always been an option. Some people have always just said, oh, we might to or not, before they actually went back, so thank you. Does the look at our insurance increase include the cost of the levelized flat on the voluntary and the possible savings from Surgery Plus?
No.
Okay,
Those are all status quo projections.
perfect.
And so they don't include plan design changes. They don't include changes to your stop loss threshold. They still include an increase to your ASO that we know you're not going to get. So they're still more conservative than what we might expect to see from some. But we like to be conservative.
Right.
We'd rather, overestimate and then make sure that the plan is protected, specifically with the health of the plan today.
No, I really appreciate it. That was great, because you don't know what kind of anomalies you don't want to put on there, you know what I mean? You don't want to try to adjust for those things, but there is a good opportunity in that we might be able to save a couple of dollars, but we don't want to judge for that. We want to plan for the future. I wanted to get back into the dental, I'm going to take this damn thing off, dental, self-insured dental piece. Just so you guys know, I just want to let everybody know, dental's a different piece than the ASO and the pharmacy and all that stuff, because it's capitated. So it's not like it can run off like medical claims. So you know what your risk is going out over the last couple of years. And correct me if I'm wrong, and you guys can say it if you want, self-insured dental rates are lower dental rates than they normally are if they're fully insured, just like a fully insured versus self-insured. The only negative to it is that we have to take on more responsibility in claims data. Right?
Agreed.
But the key is that it might be an opportunity for us to provide a low-cost, high-quality dental insurance to our people and carry a reserve that we might be able to use to keep that dental flat, to levelize costs over the years or offset some other areas that we have. It's a great opportunity. But I wanted to ask, because I know that there was some confusion about the DHMO moving to the self-insured model. So if you have, say, one carrier that comes in really good on the DHMO, and then the self-insured PPO is better than the fully insured, that would be the plan, would be a self-insured PPO and a fully insured DHMO?
Yes,
And
ideally
it could be
with the
two
same-
different carriers. It's unbundled, right?
Ideally would be with the same carrier.
Right.
So we would need direction from the board to specify that we would want separate carriers for that. And it would be a different decision point for the employee, not just PPO or HMO. It would be a matter of network. It would be a matter of cost. It would be a different level of disruption. It would be a second dental EDI file between the two. Some carriers won't split it. Some won't want to split the business to just have the DHMO and just have the PPO self-insured. We actually didn't specifically ask that question in the RFP. We asked specifically for them to include proposals for both funding alternatives, but we did not specifically ask them their stance on splitting the business. So we would have to lay that out if that were at the will of the board.
And I would say one other thing, a positive of keeping it with the same carrier is that the DHMO is typically, because it's capitated, it's number one, it's more predictable in terms of the profit that the carrier makes. And they're going to give you a more favorable administrative services rates on your PPO plan if they have the DHMO piece.
Right.
So if they're competitive on the DHMO piece, and they can get more aggressive, let's say on your fixed cost for the dental plan, that's your best of both worlds, is keeping it together. At least that's my experience up to this point.
Yeah. I think from my perspective, if the self-insured dental model is better for our employees, lower costs, and create it, and it comes from a separate carrier, the EPI feeds are going to be, they're flat rates anyway, flat files that come in. The DHMO can come from a different carrier as far as I'm concerned. I just want to do what's best for our employees, that's all. But it does make sense, and it's better if it comes from one carrier. But if I was watching this video and I was going after the RFP, I didn't want people that were out there that might bring a strong PPO to not bring that to the table. You know what I mean? Because of it. So that's all.
Sure.
We got the levelized flat. I want to thank you guys for coming back with the levelized flat. It's going to be a great thing for our organization. We're going to be able to offset some of the costs inwards of close to $500,000, probably, if not more. And that's something that you've tried to do for a long time, and I think that's a good opportunity for us. Thank you for doing the marathon health evaluation. Oh, one thing that I did want everybody to understand is that our ASO PBM contract with Cigna has and I know you guys have been reading on this, they have given us discounts, right? And when I was talking to Mark Lingdorf last week, and I agreed with him, those discounts would have to be paid back if we went out to market to go out to RFP. So keeping Cigna and reevaluating the contract exactly like you guys have done, and then looking into the future of doing an RFP is the proper process. But not jumping the gun and then all of a sudden going out, and then we have to pay back $2 million or whatever it was in fees. So the process you guys are on it, great. Evaluate the claims data and everything else, and don't jump to any guns. So I really appreciate that.
Yeah, and just one other comment. You know, our pharmacy team has already been in touch, you know, with Cigna, and we're back and forth as far as the timing of this. But the worst case scenario between contractual changes and some additional improved rebates, et cetera, there is going to be, you know, and again, I don't want to cat out of the bag until we finish the negotiations, but there's going to be some additional savings to the district for that. And that, like I said, worst case, that'll be 1/1, you know, 22. Okay, we're trying to push it earlier, but again, we're still in negotiations. So
That's it. Thank you. And then I owe you a huge thank you to Dr. Theddy, because I drove you crazy for about 2-3 weeks over all of the things that we have inside here, and I really appreciate all the hard work that you put into dealing with me, calling the meetings, going through each one of the processes, the procedures, what was inside I just want to say thank you. And thank you guys for your team, for everything that you guys have done. I'm so impressed with what we have here. I'm so happy to move forward. Thank you. I've heard you're amazing from every one of the staff people. So I look forward to this. It's really bright. Thank you. That's it.
Thank you.
Thanks.
Any other questions? No?
I have a couple, actually. So and Mr. Susan alluded to the fact that one of our frustrations, I think, as board members for years has been the lack of data that has been available. And we often hear that this is proprietary data and we can't have access to it. And so I'm super excited for the information that you guys are going to be bringing to us, because we too are very data-driven in everything that we do, right? So staff will tell you we like to get down into the minute details of that stuff. But I'm curious, how are you guys able to have access to that information when other people have said that we're not able to have access to that? Like, what's the difference? Or is that like proprietary information that you can't share?
no, we would tell you, but we have to kill you. No, no, we actually have signed agreements with all of the major carriers, including Cigna. We obviously have to sign, you know, NDAs and confidentiality agreements, all that kind of stuff, and for HIPAA purposes as well. So there's several different like hoops we had to jump through, and we also had to agree not to share the information in such a way that their proprietary, you know, discount arrangements would be open to their competitors. So other than that, you're gonna get a lot of information when you start seeing. I mean, these full InfoLock reports can be as much as like 200 pages, and you're gonna probably ask us, "Hey, can you slim it down a little bit? You know, and give, you know, where's the executive summary?" And we do, but it's again because we love data. I think you're gonna really like what you're gonna see, and at least it'll arm you to understand what's going on. You may not like what's going on, but you'll understand it. And that's our goal, is to get you there, because that's a good starting place.
Perfect.
And that's one of the reasons it takes so long, and why we don't have it is because of the depth of the information that we're asking. We're not just asking for premiums and, you know, paid claims. I mean, we're asking for very detailed information. So it takes some time to load that in there, and then every month it gets refreshed so that we have the most accurate information available. And this came up in the SIAC, wanting to see that the data analytics as well. And we committed to the SIAC Data Committee that at any point in time, once we get InfoLock up and live, we can show that live and do live pulls. If they want specific information, we'll be able to pull information on demand and also give them the information that they have not had in years past. I'm sorry, what were you going to say?
The consultants can also receive HIPAA-protected information. So they will have that information. The information that they will share with us will not be identifying information. So that's the benefit of having a consultant in place, is they can do the work and look behind the scenes, so to speak, that we don't have access to. And because we want to make sure our employees are still confident that we're not utilizing their protected health information against them, so to speak. But they will be able to scrub that information and provide that to us in a way that we can look at it from many different angles, and that's the great part of having them on.
And
Good
that,
point.
thank you, Mr. Langdorf, for that, because that was actually my next question is, as much as we love, you know, the details and the data and understanding everything, we also want to make sure that our employees know that their information is protected and that we're not, the district is not receiving that information to take any adverse action or anything like that. So thank you for that clarification. I think that's important. On the Hinge Health, obviously, the most obvious incentive, I should say, for employees participating or plan members participating in the Hinge Health is not having surgery, ideally, right? But is there any other incentive for them to participate beyond just potentially avoiding surgery? Are they saving money? Are they?
Well, so the physical therapy that's part of that 12-week program isn't going to cost them anything out of pocket versus if they were actually going to a physical therapist and incurring those charges under the plan.
And so then my next question is, because I think this is such a phenomenal idea, is there a Hinge Health type opportunity for things other than surgery avoidance? So for example, like my father-in-law is currently taking advantage of physical therapy. But as soon as his doctor says you don't need this physical therapy anymore, he's going to stop doing those things because he's just not self-motivated to keep doing them, right? Is there an option? Because I feel like so many times the issues that we're dealing with are exacerbated by a lack of activity and lack of healthy lifestyle. So is there like an expansion of Hinge Health where we could
To allow really anybody to participate?
yeah, or even, you know, physical therapy in situations where it's not necessarily going down the road of surgery, but, you know, they need physical therapy for a certain amount of time.
I believe if it falls in that musculoskeletal category, they're not going to turn anybody down unless they were in that exclusion criteria, which is comorbid conditions, a recent surgery, an acute injury, which, you know, is not what we've been talking about with respect to implementing Hinge Health. So if, you know, you break your leg skiing, that's not who you're targeting. It's the chronic pain, you know, the bad knee for 10 years. So that's the person. So if anybody calls and they don't screen out for those two reasons, I wouldn't expect them to be kicked out for any other reason than that.
Okay.
In addition to that, with our contract with Cigna, we have RN Health Coaching as well as with Marathon Health. So in a situation like you described, those RN Health coaches can help develop a program for our employees to help them do an exercise program, a weight loss program, or anything to control those comorbidities that they're suffering from. Because that's the goal of RN Health Coaching, is to reduce that. Cigna has it both in person, because we have one person that's in our offices now. Marathon has one as well. So we have two in person in the district. Cigna also offers telephonic RN Health Coaching to anyone. So you might have seen, if you've gone to the doctor and received a letter saying, please contact Cigna, or Cigna will call you. What they're offering to staff is that sort of RN Health Coaching telephonically. Most people would like it in person, but if they take advantage of it, they really see some changes that are beneficial to them.
Super, thank you. And then the other question that I had was with regard to our large claims. Are you seeing trends within those large claims? Like out of the 266 that we had last year, are 75% of them for diabetes complications or cardiovascular issues or?
Right. And that's really what our clinical care team is looking at as well. So we're going to do that deep dive once we get the InfoLock analysis in, because right now the way that the large claimants come over the information we have has a single diagnosis. And that's just the primary diagnosis. If they came in with a broken leg and had a heart attack while they were there, it's going to show up as a broken leg. So we have to be very careful of what we're looking at in the data. So we try not to go too far into the raw data until we can pull it out through InfoLock. So it's absolutely something that we're going to bring back to you if we see that, and if it's a trend that has an actionable plan that we can make to avoid that in the future, then we're going to bring that plan as well.
Yeah, I'd also like to comment, and again, this is more broad-based. We're seeing an escalation over the last several years in large claims, not only the frequency of large claims, but also the severity of large claims, and that's across the country. And we're actually seeing that because of that, the medical stop loss carriers, we're kind of moving in toward a hard market, if you would, which is you're more of a property casualty term, but basically that's something that is taking place. We actually saw the big increase beginning post ACA, when there's no longer, you're not allowed to have caps on your medical plan at $1 million or $2 million or whatever. And again, I always say follow the money trail. When providers realized that there was no end to what the plans would pay. I don't believe in coincidences, but it is what it is. And right now we are seeing an increase overall, if that's helpful information.
Super, thank you. Anyone else have, Dr. Mullins, you look like you want to?
Yes, just a couple things real quick. One, I want to acknowledge when we began the relationship with Lockton, I met with them early and I expressed my expectation that they help lead the two subcommittees you've heard referenced. So I let the board know a few months ago that my intent was to initiate two subcommittees within the SIAC organization, one around health and wellness and educating our employees, and the second around that data analysis piece, because the monthly SIAC meetings were becoming a reiteration of the same data we heard from the month before versus what are some actions that others are bringing to the table for SIAC to be aware of. So I want to express my appreciation to Lockton for being the key leader in those committees to bring information to equip the subcommittees to do that work. And then second, as we're in the throes of budget season and preparations for end of fiscal year and new fiscal year and so on, I suspect what caught your attention was the fund balance shortfall as of June 30 in anticipation of meeting our 112.08 fund balance requirements. And it's in the $5 to $6 million range, depending on how things vet out at the end. So just a reminder to the board, we have already set aside $2.35 million that was part of this fiscal year toward the $4.7 million recurring contribution on behalf of the board that didn't go into effect until January 1, 2021. So only half of that $4.7 million was needed for recurring in this fiscal year, leaving the $2.35 million available, and we've been anticipating needing to infuse money by the end of the year. So that 2.35 is set aside. In addition, you remember I met with you over the last couple weeks, and right now Cigna has presented that we have approximately $2.4 million of COVID-related healthcare costs that are refundable or covered through our ESSER funds. So we're right at about $4.75 million towards whatever that contribution is by June 30th. So we anticipate being able to meet that obligation, or at least getting very close with funds we already have set aside for that. So I wanted to provide that to the board as well. Just to let you know, we're already thinking and preparing for that and very aware of what that financial obligation is going to require.
Thank you, Dr. Mullins. Any other board members have any follow-up questions? All right, thank you to our Lockton team and Mr. Langdorf, Dr. Theddy. We appreciate you all spending some time with us this afternoon. We're excited for what's coming ahead, and we appreciate all the work you're doing.
Thank you.
Thank you. And at this time, I will turn our meeting over to Mr. Gibbs, who is going to be walking through our drug-free workplace. Mr. Gibbs is requesting a 5-minute break, so we will take a 5-minute break and then reconvene. right. Our workshop is back in session, and with that, I will turn it over to Mr. Gibbs and team to proceed with discussion of our drug-free workforce policy.
Thank you. Good afternoon. We're here today to talk a little bit about the school board's drug-free workplace policy, given the discussion that was had at the board meeting in the past month. And today's goal is to provide a legal framework for medical marijuana as it pertains to BPS's drug-free workplace policy, go over federal and state law and legal implications of the drug-free workplace policy. So starting out, I want to clear up some terminology. In the legal realm, terminology always matters. And you've been hearing a lot about prescriptions have been given for this, and Florida has legalized marijuana. And those are some poor choices in words. Those are legal words that carry significance to them. Or a prescription is an actual object in the medical world. It comes with doctors, I don't know what they call it, it's almost like a social security number, so that the DEA can track a prescription all the way through the pharmacy. So that prescription goes, it's affiliated with the doctor, it goes to the pharmacy, and the DEA can then check and audit those records to know how much of a medication is supposed to be given out. As the DEA is over that, you cannot get a prescription for marijuana, period. They cannot issue it. So when people say they have a prescription, they mean they have whatever that state has authorized as a workaround federal law. Federal law prohibits marijuana to be prescribed. DEA regulates that. They apply federal law. Federal law is a Schedule I narcotic. It is not legal. Right? So that touches on the legality. Florida cannot legalize marijuana, even as medical marijuana. No state can. Marijuana remains illegal throughout the United States. It is a Schedule I narcotic. So when you say we've legalized it, that is a misnomer. It is simply that Florida has authorized the use of marijuana in contravention of federal law. Schedule I narcotic, when you look it up under the CSA, and it'll be here in a minute, part of the definition is no recognized medical use in the United States. That's how the federal law has it defined. Therefore, it is completely illegal in the United States, including Florida, Colorado, Washington, Oregon, Michigan, and the other 30-plus states that have authorized medical marijuana use. All right? So I did want to point that out, just as there is a lot of danger to loose language that is going around. All right. The prescription myth, I just kind of went over. DEA regulates prescriptions. You can't get a legal prescription. And it's still illegal under federal law. So Civics 101, federal supremacy. As everybody remembers from their high school days, the Constitution is the supreme law of the land, followed by federal statute, and the states can't circumvent federal law. That's the preemption doctrine. Florida law right now is in conflict with federal law. So if there's a challenge, federal law is going to win the day, and federal law says marijuana is illegal. That's why, again, you can't get a prescription for marijuana in any form. All right. There it is, marijuana in all forms, illegal under the federal statute as a Schedule I narcotic. There's the definition of Schedule I narcotics, A, B, and C. Subsection B, drug or other substance has no currently accepted medical use and treatment in the United States. There's a case there that I cited. There was a push to force the DEA to reclassify marijuana, and the appellate court there said no. They refused, and they said that the DEA had good grounds for maintaining it as a Schedule I narcotic. That was in the last 20 years. I want to say it was in the 2010 to 2018 range on that case. I think it started in 2013, and the appellate case came down in 2018, if I recall correctly. So that is relatively recent in our history, where the federal court system has heard this push to move it from Schedule I as far as mandating the DEA to do that, because there's recognized uses, and that was the argument of the Americans for Safe Access there. And the court said, no, the DEA still has good grounds for maintaining it as a Schedule I narcotic. So that moves us to the Florida Constitution. In 2016, voters passed a constitutional amendment. Again, that cannot circumvent federal law. Federal law still remains in place, Schedule I narcotic. The constitutional amendment has several carve-outs there, including that we are not required as a place of education and a place of employment to allow medical marijuana use at our facilities. Nothing in this section also requires the violation of federal law. By allowing medical marijuana use in schools, you would be violating federal law. Therefore, the state cannot force us, and it's in the Constitution that we cannot be forced to allow medical marijuana to be used in our employment facilities. Florida statute, the legislature passed to implement the constitutional amendment. In the definitions, you'll see the workaround of federal laws on the prescription formula there. You get a physician certification from a qualified physician authorizing the use of marijuana and marijuana delivery device from a medical marijuana facility. That's the workaround that I was describing earlier with the DEA. DEA prohibits or doesn't recognize any marijuana use as a medical device, so they've gone to this. We call it physician certification. Other places have other terms for that. And there's the other definitions that are all used in there. And we'll move to Florida statute continues in section 15 to limit the applicability of medical marijuana. I'll point out that subsection A there does not limit the ability of an employer to establish, continue to, or enforce a drug-free workplace program or policy. Subsection B does not require an employer to accommodate the use of medical marijuana in any workplace or employee working under the influence of marijuana. Subsection C, section does not create a cause of action against an employer for wrongful discharge or discrimination. So even in the implementation, the legislature said that employers in Florida do not have to allow marijuana to be used in a medical form. They don't have to accommodate it. They can maintain their drug-free workplace programs. All right, the Florida legislature there has not gone so far as to require public employers, as such as us, to accommodate this use. There is, and you've heard discussed at board meetings, a bill currently in the legislation to do just that. However, even that bill has carve-outs that, such as, would not cause the employer to violate federal law. As I said, federal law, it's still illegal. So any use that is mandated by the state would be a violation of federal law. So I believe that it would still be there, that carve-out, for us to decide whether or not we want to use it. Even if they said flatly, if the final bill that came out, if it were to pass, and I do not believe it will pass this year, I believe you could still push back on federal law grounds because, again, preemption says federal law prevails, and this is in direct conflict with the current federal law. So until Washington changes Schedule I narcotic or takes marijuana off of the Schedule I narcotic list, there's always going to be that ability to say that as an employer, we are not going to allow marijuana in any form to be used by our employees, because I don't believe a state can order us to violate federal law. Drug-free workplace policies in our context, It's not about just money. You know, you hear a lot about, in the newspapers are reporting, you know, everybody that's denying it is federal funds, federal funds, federal funds. From my perspective, there's a greater liability in the risk side. If someone's under the influence of a narcotic, are they as aware? Are they as observant? Are they going to be as reactive if something's going wrong to prevent something that is preventable? If a student's doing something they shouldn't be and someone's under the influence, maybe they aren't as observant. Maybe they aren't as quick to react and prevent that student from doing that. And if something happens to that student, even under the best of circumstances, we're getting a 768 notice that we're going to get sued from somebody alleging that we were negligent. If they find out that somebody was under the influence of marijuana, even a medical marijuana with the physician's authorization, you're still going to have an attorney in a courtroom saying that, hey, we support the use of marijuana, but not in every job, not in every context. You have to pick and choose, right? If they're in a security situation where they're observing and they're responsible for somebody else's safety and, you know, the safety of someone's children in our case, which is extremely high. And I'll get to that in just a minute on the constitutional amendment you'll see there. Safe, secure, high quality system of public education in the schools. We're responsible for people's children, all right? If something happens, we get sued, like I said. If we have people under the influence and we're authorizing that, they're going to say we shouldn't have authorized the medical marijuana to be used by those individuals. It's going to create liability on the district. I think in far greater amounts than simply we're going to lose federal funding. That's still a possibility, and I won't discount that completely. But when you say, has anyone lost funding, I can say I haven't heard of anybody. I also haven't heard of any district that doesn't terminate employees for using medical marijuana. And I've talked to attorneys for school districts in Oregon, Colorado, and Michigan. And they've all said the same thing. We're terminating employees for using medical marijuana still today. Oregon's case, they've decriminalized the use of almost all drugs when I talked to their attorney. So, and you can use drugs and you don't get arrested or charged in Oregon. So that is an anomaly there. It's still illegal. Like I said, they can't legalize the use of heroin in Oregon. It's an illegal drug. That state, just like Orlando over there, has decided not to arrest and charge for possession of those drugs. But it's still an illegal drug under federal law. 11th Circuit Court of Appeals has issued a decision, and that is the Friedenberg case. It's a really good decision, and if you have the time and interest, you might want to walk through it. There's a lot of analysis in there about safety-sensitive issues dealing with teachers. The case specifically deals with drug testing substitutes. The argument was we shouldn't be drug testing substitutes because they aren't really an employee, like full-time responsible. The court disregarded that and said, no, they are. They're responsible for safety. If something goes wrong, they need to be alert and everything. And they walk through all of those issues and the analysis of safety-sensitive nature of the substitute and teachers in general that would allow for the district to drug test those individuals. And they actually upheld the decision in that case in Palm Beach to drug test all of their things. And it's one of the seminal cases that is like, hey, as a school district, our teachers and our employees at the school sites are security-sensitive positions, and we do have a need to drug test and make sure they're all going to be alert and at their best day in and day out. And here's the federal grants. I won't harp on this too much more. I will just point out, like, if we don't maintain the drug-free workplace, and we are recipients of federal funds, and you can't check the box. There's a box on all those grant applications that come in that says you maintain a drug-free workplace. I can't advise staff to check that box. Those carry, like, you've all seen it. You're certifying under federal law that these are true and accurate statements to the best of your ability, subject to perjury requirements. And you can be charged in a criminal court. If you're saying, hey, we're going to allow this, and it's an illegal drug under federal law, that's what they're going to apply when they analyze that grant. So if someone checks that box and we allow marijuana use in any form, I don't care medical or otherwise, we're violating federal law. So when they look at that, they're going to. I'm going to have to say you can't certify that we are a drug-free workplace if you're allowing it. So from that perspective, you might not even know that you're losing funds because we apply for grants, and there could be 1,000 other school districts applying for that same grant. The analysis might come down at their end saying, hey, we have 5 school districts that we can award to for this money. This one doesn't maintain a drug-free workplace, so that one's out, and we're going to give to these other ones instead. So you may never even know. They might not say, hey, you've got this money, we want it all paid back because you're not maintaining a drug-free workplace. That might not occur, but they might say, hey, we're not giving them any more money. And if those districts in Oregon and Colorado who are still saying we're maintaining a drug-free workplace, and they're certifying that, they might be getting your money instead of a district that's, out there saying we're not going to maintain a drug-free workplace anymore. And to my knowledge, no one's doing that. So I think that could be the hesitancy here. Who wants to be the first one out of the gate to test the federal government on what they're going to do and whether they would lose any funds? Florida's drug-free workplace. The Florida legislature created the Florida Drug-Free Workplace Program in 1990. And in order employers would be afforded an opportunity to maximize their levels of productivity, enhance their competitive positions in the marketplace, and reach their desired levels of success. All right, 1120455 Florida statutes provides the use of illegal drugs and the misuse of prescription and over-the-counter drugs are unacceptable. Florida Workers' Compensation Program, also tied to the Drug-Free Workplace Program. An employer who becomes certified drug-free is afforded certain benefits, and you can see those benefits there. Criminally, just like the federal statute, marijuana or cannabis is still a Schedule I drug if you look at our criminal code in the Florida statutes, despite it being in the Constitution. So, and there's the Schedule I in Florida statute, Section 893.03 sub C7. Substance in Schedule I has high potential for abuse and has no currently accepted medical use and treatment in the United States, and in its use under medical supervision does not meet accepted safety standards. They mirror pretty much federal law on that definition. They're maintaining their criminal code with the Florida or the federal criminal code level there as a Schedule I narcotic. And then I'll turn it over to Dr. Theddy.
Sorry, I forgot to turn on my mic. Good afternoon. I'm picking up the presentation at the Policy and Administrative Procedure Applicability to Staff level. As you've already heard, we have a drug-free workplace policy, and the technical guide is incorporated by reference. This message is communicated yearly to all employees during the required self-paced pre-planning activities on the ProGo system. In addition, for all teachers who are new to BPS, one of the peer mentor teachers provides specific information regarding drug-free workplace and marijuana to include medical marijuana during that new teacher academy. Although it is not required, we do see great participation of our new teachers in that program. The technical guide it has been accused of being ambiguous, but we do specifically mention marijuana metabolites, and cannabinoids in the technical guide. And in a later slide, I'll go over several pertinent definitions that are really germane to this discussion. Sorry, I forgot to advance the slide. The objectives of the drug-free workplace policy include healthy and safe working environment for our employees, hire and retaining drug-free employees, providing a model of behavior without substance abuse, and you can read all the others on the slide. The Drug-Free Workplace Technical Guide has guiding principles to ensure we uphold these and provide an environment for employees in which they may work and students may learn. The applicable laws and rules have not changed, even considering state statute and medical marijuana, as you've already heard from Mr. Gibbs. Marijuana in all forms is a Schedule I drug under the Federal Controlled Substances Act and is illegal on the federal level. Florida Statute 381.986 still provides for employers to maintain and enforce a drug-free workplace. On this slide, you can see a carve-out or a piece of the policy where employees on duty or on board property will not manufacture, distribute, dispense, possess, or use illegal drugs, and that employees are prohibited from working on board property while under the influence of illegal drugs or under the influence of improper use of legal drugs. This is the section I alluded to a little bit earlier about some of the definitions. Contained within the drug-free workplace policy are definitions which include controlled substance, the definition of drugs, where you can see cannabinoids are specifically mentioned, and illegal drugs that says in part where the article is prohibited by state or federal statute, state or federal regulations, or employer policy. Also in this section of the technical guide related to testing, marijuana metabolites are specifically mentioned both in the initial test and the confirmatory test information in that section. This section of the policy regarding positive test results has been applied to both job applicants and employees. If there is a positive drug test result for an employee or a potential employee, the medical review officer, or MRO, consults with that employee before we even get a result back. And if the information in the prescription or the material that the employee or prospective employee has been prescribed matches what they found in the level in the urine, then we get a cleared drug screen. If it does not, or if the drug screen identified use of an illegal drug, we end up getting a positive result back. And this is just more information about reporting the results for employees and applicants. Like I said, it's not returned positive until the MRO consults with the employee or applicant, and we simply get back a positive or negative drug result and what drug they tested positive for. We do not get back levels or anything like that. The next two slides pertain to the disciplinary framework in the policy. The policy covers the range of actions that may be taken. There will be an opportunity later in the presentation where Mr. Langdorf will refer to the aspects of this section in his risk management slides, and Mr. Gibbs, in the second to last slide, will lead into board discussion of the policy. As we discussed at the board meeting 2 weeks ago, there are options within this framework. This is off of, when you print out the policy, it's on page 6 of the policy, and this is the A through D that we talked about at the last board meeting. There have been a lot of questions related to a student policy versus a policy for the employees. As it is indicated in this slide, statute is specific to the development of a policy for students, for a student who is a qualified patient, to use medical marijuana pursuant to this section. Of special interest in policy 5330 is the statement, for the purpose of this policy, qualified patient applies only to students and does not apply to employees. That's in our student policy. Further, board employees, school-level nurses, and/or healthcare personnel or school staff are not permitted to administer, store, hold, or transport medical marijuana in any form, and it shall not be stored on any property owned or operated by the board at any time. It's really important to note when we're talking about a student policy versus an employee policy that teachers and school staff are not students over whom we act in loco parentis. Teachers have a variety of safety-related responsibilities to include monitoring students for safety purposes, such as preventing or stopping fights, reporting and addressing hazards or other unsafe circumstances, and detecting and promptly responding to student health and safety issues. As you previously heard from Mr. Gibbs, the Friedenberg case said that even a momentary lapse of attention could be the difference between life and death, and while the magnitude of public safety risk presented by an impaired staff member is not the same as the risk from an impaired, like, for example, in Friedenberg, they talk about railway operator, the special responsibility for the care of society's most vulnerable members is distinct and notable, and that's out of the Friedenberg case. Mark Langdorf will take over now, and he'll talk through the risk management and workers' comp aspects of our policy. You want me to just do your slides for you?
Yes, that would be great if you would. Good afternoon, everyone. I thought what I would do today during my presentation is focus on it from a risk management, focus on the use of marijuana from a risk management perspective, along with how our drug-free workplace deals with marijuana and the risk considerations that we have to look at whenever a claim is filed against the district, because that falls under the risk management responsibilities. The first thing I wanted to talk about was basically what the Division of Workers' Compensation puts out. And they just updated this as of September, and it's the Employer's Guide to a Drug-Free Workplace. They have a lot of information within this guide that talks about the different things that happen to employees on the job. But the things that they focus on most for those who have a drug-free workplace is that they will have a safer work environment, that there'll be a happier workforce. And some might think, what is that about? But here's ultimately, there's a paragraph within this guide that says this: all employees are aware of the importance of safety in the workplace. Drug-free workplace benefit from a safer work environment for all employees, because those who are under the influence of drugs do have a tendency to not do the work that they should be doing or not supervise kids properly. So that's why it's an important thing from the Division of Workers' Compensation perspective. In addition to that, the division encourages those to have a drug-free workplace that would also include cannabis or marijuana, because then we're assured that the injury that might occur, which are very costly under workers' compensation, are not based on a drug-induced accident. They're based on real injuries or accidents that occur in the workplace. The next part of my presentation, I want to kind of focus on something that I think is important. There is absolutely no way to verify impairment at this point. There's no test that shows that. There is some risks of liability assessments, and there are some insurance implications for employees to consider when they are taking drugs at work. As far as impairment is concerned, which is the next page, cannabis has an effect on the human body this way. It affects their knowing, their thinking, their judging, their evaluating, and their planning aspects. Those who are under the influence of that drug, regardless of where it had happened, their thinking is slowed, their actions are delayed. They're oftentimes, if they're more addicted to it, because marijuana, I've heard the expertise that marijuana is not addictive. It can be addictive. Those who go without marijuana for a long period of time become agitated and anxious in the work environment. So that has an effect on everyone. The tetracarbonyl THC, which is the active ingredient within marijuana of itself, is not, as I stated earlier, is not easy to detect. You cannot detect impairment because part of that reason is it's metabolized differently. People's body size, their composition, there's just no test that'll tell you how impaired an employee is at this point. The National Institute of Occupational Health and Safety is trying to come up with tests or ways to figure out how to find out if somebody's impaired, but at this time there just is no test to define that. There is no minimum threshold for anybody who's behind the wheel. So you might look at other states that have marijuana as a recreational drug, and that there is no way to determine what that impairment is when somebody gets behind the wheel. Some might say, well, we have DOT drivers versus employees. The DOT will have marijuana within that. If it was to change to somebody else, we still have teachers or others driving students in their own vehicles, or we have parents who volunteer. The last thing we want is to put kids in cars where somebody has been under the influence of THC. The one thing I thought was interesting here, though, if you look at what they're saying in Colorado, drivers with a 5 nanograms of delta-9 THC are considered DUI there. That's a very, very low number in Colorado, because they will arrest and prosecute somebody on a DUI for just having that 5 nanograms of THC in their blood system. Another thing that I thought was interesting when I was doing the research on this, I looked at the National Institute on Drug Abuse, and what they indicated spoke volumes to me because I deal with the workers' compensation claims for the district, and that is they found that there are 55% more accidents, 85% more injuries, and 75% greater absenteeism. So it's not just accidents, it's people not being at work among those who have tested positive for marijuana compared to those who tested negative for marijuana. So there's great implications there from a risk perspective, an injury perspective, as well as what's happening in absenteeism rates with employees. Also, going back to the accident, the National Safety Council found that nearly 2/3 of the U.S. trauma center admissions from a motor vehicle crash, 65.7 of those people are testing positive for drugs and alcohol in their system. And what's interesting about that, in my view, is most people will get behind the wheel of a car because they think they need to get to this location and they've built up a tolerance. They're not aware that they're impaired at the time, and that's why most people will get in a vehicle and drive with kids or anybody else in the car. From an insurance perspective, I looked at some of these, and not all carriers treat things the same. So I'm not going to say our carriers would do this, but I think it's important to say this because I think this is very true. Disability insurance carriers, the district offers all of those who wants to sign up for a short-term or long-term disability where they're automatically, it's a guaranteed issue. If they don't sign up during that first year, every year thereafter, it's on a non-guarantee issue. So what happens is the employees have to fill out a questionnaire. And if they list on that questionnaire that they're using marijuana, they will be considered a smoker for the most part, and their rates are up. So there's an implication for those who are buying disability insurance. For those who have had a disability claim that's filed under there, whether it's due to an illegal drug or a non-conventional drug, which you might call medical marijuana, if the major contributing cause to that disability is likely due to that drug, the insurance carriers will have the right to investigate, and they could possibly deny. I'm not saying they'll do that every time, but they have the right to do that typically in their policies. The same thing happens when it comes to life insurance policy. So if there is a death that occurs and they can point to the major contributing cause being that drug, those claims could be investigated and possibly denied. Interesting enough, Social Security will also consider that. So when somebody has a disability and they seek Social Security disability payments, Social Security will look to find out why they are disabled, and if they can point to it being related to illegal drug use and that, they can have a tendency to deny those claims. What affects us within the district is workers' compensation, because under workers' compensation law, it's presumed that when you're using any sort of drug, whether marijuana or any other, and they don't distinguish between medical marijuana or the other, that accident occurred because of that drug. Now, they can fight that, and they can try and say it's there, but the presumption is that marijuana or that illicit drug caused the workers' compensation claim. Interestingly enough, even for unemployment, if somebody were to be terminated because they were positive for a drug screen, and it was one of those illicit drugs, they could be denied benefits. So from an employee perspective, they lose their workers' compensation claim because that claim is denied, and they can't apply for unemployment. Well, they can apply for unemployment, but their claim would be denied because they were using that drug, and that was the reason for termination. So I think that's an important thing to look at. When we evaluate claims and risk, and this page is probably, this particular PowerPoint slide is one that means the most to me, and that is when a claim occurs. Typically, somebody is going to look and find out what happens from a supervisory perspective. And remember what I talked about earlier with the use of cannabis. It affects an employee's knowing, thinking, judging, evaluating, and planning. And remember, there is no test to determine whether somebody is impaired or not. But if somebody is using an illegal substance, regardless of whatever it is, the focus of the claim will be, what did the district know and when did they know it? If we hired somebody who's utilizing an illicit drug, and that results in an injury to a student or to anybody else, the claim against us will be for negligent hiring because we knew or should have known that they posed a danger to the employees or anyone else in the workplace. In addition to that, the biggest issue we have as a school district is supervision. If we have people in our employ that we know are utilizing a drug that impairs their thinking, their knowledge, their reaction time, and we allow that to happen, claims like that will be questioned, and it'll be much harder for us to win a case on supervision if we know that that person is utilizing those drugs. In addition, when we know somebody, especially even on a post-accident drug screen, if we don't take any action to correct them, or we don't take any action to eliminate those who are utilizing drugs in the workplace, if because of that something occurs, those claims become much more difficult to defend, and because often it's very hard to say that they are properly supervising. And we were aware of that situation. Most every claim we have filed against us, and that's claims that go from just a regular student accident insurance or student accident claim or litigated file, when those occur, those are the questions that we get asked. So any modification to the policy, I want you to think of how that could affect that. And that's where the issue comes up when it comes to playground accidents. If a child injures themselves in the playground, the first thing they always ask is, where was the teacher in relation to the accident? When we investigate claims, we're looking to validate those distances, finding out where they are. Did we have sufficient adults to supervise the area? If they're under a drug that impairs their thinking or their ability to react, that hurts us in any sort of case that's filed against the district. From a risk perspective, bringing drugs and bringing them or making them more available is much more difficult to defend, and it will be much harder to defend those cases in the long run. That's my risk perspective. I'll turn the time over to Mr. Gibbs.
Thank you. The purpose of today was really to determine whether the board has any desire to amend its current policy. And we wanted to provide a full foundation of the legal standing and the risk standing and the HR standing for that discussion. From my perspective, and I don't know about the others here, our current policy is non-ambiguous. It prohibits the use of marijuana, period. All right, if you have cannabinoids in your system when you're tested, you will be in violation of our policy. If the board wishes to amend that to explicitly state inclusive of medical marijuana, it is obviously free to do so. The board has maintained this same drug-free workplace policy dating back to 2004. Right? So everybody understood in 2005 that they weren't allowed to smoke marijuana, or they weren't allowed to use marijuana. They weren't allowed to eat brownies laced with marijuana. They weren't allowed to take gummies that had THC in them, and if they did and they tested positive, they would be disciplined for violating the school board's drug-free workplace policy. They knew that in 2010. They knew it again in 2015. All right, to argue that our policy is ambiguous now is disingenuous. Nothing's changed. Literally, nothing has changed since 2004. Current policy prohibits marijuana, once again, in all its forms, period. Just like federal law, marijuana, period, is illegal. If an employee is unclear about whether they can take a drug that is being offered to them, they should reach out to HR and ask, hey, what are the implications of taking this? All right, just like they go over, you know, if you buy that CBD oil at the gas station on your stop, they warn you that if you take that and you use that oil and it's in a lotion or whatever, and you test positive, you will be disciplined. And that's something you can just buy at the gas station, and they're selling it at the gas station. You don't even need a doctor's authorization. So my recommendation would be, if you want to consider this, and my recommendation first off is, unless and until we can determine impairment, as Mark Langdorf was going over, we shouldn't be allowing it at all because of the risk factors that he went over: negligent hiring, negligent supervision, negligent retention. The liability risks there are pretty high, and John Morgan himself will probably represent plaintiffs if something happens to a student, and he was the driving force behind getting medical marijuana constitutional amendment passed. So given the high stakes and implications as far as the drug-free workplace policies, if you wish to entertain an amendment to add that negligent or medical marijuana is inclusive, or make any other changes, I would suggest that you also insulate your superintendent, whoever that may be, Dr. Mullins right now, and in 20 years from now, as long as this policy is in place, that whoever's in that position then, protect them from any kind of, you know, public beating or lobbying efforts or anything, by saying the expectation of the board is to have a recommendation for all illegal drug tests that come back positive of termination. And then that puts it on the board to decide whether it wants to allow that use or lessen the discipline in that case based on the specific facts in that case. And that just, again, takes the pressure off of Dr. Mullins. He can still, you know, meet with staff that are coming up through the disciplinary process. They can explain what happened, what their circumstances were, and if there is a compelling mitigating circumstance in that particular instance, he can come to the board at that meeting and say, hey, I believe there's a compelling circumstance in this case, and I would fully support a reduction. But the expectation of the board is any illegal drug test comes back positive is termination for the board's consideration. And I will turn it over to the board for any questions or discussion.
Thank you, Mr. Gibbs and Dr. Fetty and Mr. Langdorf. We appreciate the information. Board members wish to ask questions, respond?
Yeah, I do.
Ms. Jenkins?
Yeah. I guess I'm a little bit confused because I don't feel like any of us had expressed at some point that we wanted to allow medical marijuana. So I felt like we spent like a really long time on that. But I will say, I don't think it's disingenuous to say that people are not aware when in 2016 they voted for a constitutional amendment. And I get that we can assume that people know what that means, but I think it's safe to say that as it becomes more commonplace for people, we should then make it very clear that that's not something that we're going to allow. I think it behooves us, if it isn't allowed, to make it very explicit, to say including medicinal marijuana, because I believe we can assume that a lot of people have confusion when it comes to those myths that you stated in the terminology. The layman and most of our staff probably believes the majority of those myths, and if it's up to us to clearly state something, then I think we need to make sure that it's clearly stated, and then we wouldn't have to have these conversations that we had because of the previous case. And that's all I've got.
Thank you, Ms. Jenkins. Anyone else? Ms. Campbell?
So looking into the crystal ball of the future, because I know at the presentation that at least Ms. Belfer and I attended online for our Central Florida Coalition, it was mentioned that there's more marijuana lobbyists in Washington, D.C. right now than any other cause. So assuming, I am going to assume from the presentation, and I actually would agree, that even if federal law changes because of the risks, because of still not being able to tell an impairment level, all of that, there's still enough reason to not make that change, even if the federal government were to change that in the near future.
From my perspective, yes, it would ultimately depend on how the change is done and implemented around the states. If there's still a carve-out, then we can certainly look to those carve-outs. My guess is the state would probably jump pretty quick to amend their statutes if it comes off Schedule 1.
Right. And at such time, we'll have to deal with those consequences.
Yep. It'll be back before the board if that happens.
I don't know how the rest of the board feels, but I had asked a lot of questions on the second recommendation about insulating the superintendent. What does that look like? What would it mean for the future? I mean, if we think about a recent case, technically, whether this would be in policy or it wasn't, the board at either time, we could have a couple weeks ago or we could in the future make whatever decision we choose based on the recommendation. Either accept the recommendation or don't, reduce the discipline to something else or not. But I think it's probably a good idea to be clear. There's two things that I'd like to see. I think one of them has actually already been put into place, and that was I asked, could we in our materials that everybody sign, I know we're doing it for our new teachers, our new employees, but could we in the future include those specific words, including medical marijuana, just glaring in your face on the first page of that training every year that everybody signs off of? And I believe that may already be in the works. And then my second thing is, I think if y'all haven't looked at policy 3124, it actually is only 2 paragraphs. It encompasses the technical guide, which is a lot longer, but it's only 2 paragraphs, so it's not, so wherever we need to put it. But I think it would probably be a good idea to make this change if there's enough interest from the board to do something similar to Orange County and making this very clear that A, B, C, and D are not all available for this specific violation of our drug-free workplace policy.
And just to be clear, that recommendation is only for illegal drug use positive, so people that are illegal either under federal or state law.
Right. Thank you for clarifying that.
Mr. Susan?
So under the current drug-free workplace and hours, we're allowed to, if somebody is test positive for a drug, they are allowed to go to rehab. Can we walk through that process and still stay part of a drug-free workplace? Can you walk me through that process? So I test positive?
For discipline?
Well, yeah.
Under most of that would be HR's thing. It's certainly in your policy as far as being an option to the board.
So how, can we walk through that? How that happens?
So with illegal drugs, we have not recommended moving forward with a different alternative other than termination. But you'll have cases where somebody will come to a supervisor saying that they are having a problem with alcohol or some other drug, And, we offer them EAP, we offer them other opportunities. Once they've had the accident and they've been tested and they haven't disclosed on a legal drug, I'm not talking about an illegal drug, just a regular alcohol or some other kind of prescribed drug. Once they've had that accident, we go through that disciplinary process because there was no knowledge of that. Can you, as a board, make a different decision in those cases? That's what A, B, C, and D allow you to do in those kinds of cases. It has not been applied in the cases of illegal drugs, though.
But technically, we could go down that road and we would still be able to allow them to go to rehab, and we could still be able to keep our drug-free workplace under those standards?
You can, as long as you're disciplining and you're maintaining that drug-free workplace policy and they're coming back clean, then I think you can genuinely check that box.
Okay. And then in the current environment that we have inside of our school district, in the current environment in the school district, we allow an individual on a workers' comp claim to decide if they are or are not going to take the test, correct?
No. If they have if they suffer a work injury, they are sent to the location to have a urinalysis taken care of that day.
So we don't have any instances inside of our school district where individuals have had an accident and they've been given the opportunity to not take the drug test, to take the liability back to them.
No, that we require them post-accident to get a drug screen.
If in the future had the ability to do so, not that we would, but if you had the ability to do the individual to choose to not take the drug test, but take the full responsibility and risk of the actual accident, is that something that you've ever seen before?
I think he's asking whether, if someone's saying they aren't injured, are we still sending them? So they aren't making a claim for workers' comp. Are we sending them for testing? Do they have the option to opt out? I think that's really what he's asking.
Yeah, because I know that there's been instances since I've been on as a teacher where an individual wasn't injured, right? And I mean, I'm not talking about like a broken leg for crying out loud, but there's instances where something happens and we give them the option that, no, I'm not injured. And we always say, in that event, you're responsible for anything that might come from that. Is that?
Okay, I think I understand. I want to clarify.
Yeah,
So somebody suffers an accident on the workplace, but they're not injured.
right.
Okay. If there's no injury associated with an accident, they're not sent for a drug screen. If there's an injury associated with an accident, we mandate that.
Yeah, I'm sorry.
If they suffer a bruise or they suffer any sort of injury where they're saying they're injured at all, then they are sent for a drug screen. Whether it requires medical attention or not, they go for a drug screen as soon as they say they were injured.
Okay.
So if they say to somebody, the school secretary, for example, they say, man, this really hurts, but they think they can put ice on it, they're getting a drug screen because they're claiming an injury associated with an accident.
And they can actually, and if I'm correct, they can actually be terminated if they refuse to go for the drug
Exactly.
screen
Right, we
in
can.
that situation.
Remember the whole drug screening thing that we had years ago? Okay, let me get back to that though. So who determines that the individual is required to go to take the drug test? So if I injure myself and I'm a coach, somebody saw me take a hit and I'm like, look, man, I'm not hurt. Leave me alone. Am I okay there?
What we would do in those particular circumstances is they would write up an incident report and they would put in writing that they were not injured as a result of the accident itself. So we have that documentation on file.
And we have a series of those that we have inside files where people have written down, I was not injured.
Yes.
Okay.
Because this way, if they come back at a later date, that would have been a violation of the board's policy on drug testing.
Perfect.
If they claim an injury, they are required to get a test. If they say they were not injured, then we want that in writing to say they weren't injured. If they later develop an injury, they're even sent for a drug screen at that point.
Good. No, thank you. I appreciate it.
Sure.
I'm good.
Ms. McDougall, you had a question?
I did. So Mark, I just want to make sure anytime that something happens on the playground or in a classroom or something, is an incident report always filled out?
Yes.
Okay, so an incident report at that time is always filled out. And so if I'm following the process, they're saying, I'm fine. They check no, and so they don't get a drug screen at that point.
If they say they are not injured, they are not sent for a drug screen.
Okay. It's only if they say there's some type of injury.
Yes, if they say they were hurt
No
in
matter
any way.
what type of injury.
That's correct.
Okay.
Well, but in all reality, Ms. McDougall, and he's answering honestly, but in my head, I'm thinking through like the possibilities, right? So, I am standing on a desk and the desk collapses and I fall. And my ankle is going in 3 different directions. And I say, no, I'm not injured. I'm pretty sure that someone responsible would intervene at that point and
Yes.
say, we need
Well,
to
that's
get you.
clear.
Right, so.
If they are bleeding or there's a broken bone, they're going to be drug tested. We'll take care, and I want to clarify something first. I don't want anybody to think we require the urinalysis before we treat them medically. If it's an acute injury and we need to save their life, we do that first. Once that's resolved, they go for the drug screen. But everybody who claims injury from an accident will be drug screened.
Does anyone have any additional questions, or do you guys want to try to get to the meat of direction from the board on this, or?
I have a follow-up question. So the issue that I had brought up at the board meeting, and I think Mr. Susan was kind of hitting on it right now, but those options A, B, C, and D. So there is nothing prohibiting us from, or there's nothing in that language right now that says certain options are only for legal drugs and certain options are only for illegal drugs, correct?
That's correct. There's another section in the drug-free workplace where it speaks to the board believes rehab would be an appropriate option. I'd have to find that exact language, but it's in there.
Okay. And just for clarification's sake, because this was something else that came up at the board meeting too, as like a hypothetical. If we had somebody, because we claim we've set a precedence now to where we have to treat someone who might be addicted to heroin the same way we treated somebody who was found to be using medicinal marijuana. That person who was using heroin, and we gave them the option of rehab because of precedence, they would then have to pass a drug test to come back to work, correct?
That would be something that would need to be set up in the policy per board direction to Dr. Mullins.
So we don't have that in place already. If somebody's going to rehab, that we have to drug test them before they come back to work?
It would most likely be in whatever settlement document that was executed with that individual. Perhaps like if they came and said, hey, I have a problem, I've been under the influence of alcohol or whatever, and we allow them to go through an EAP program, they would most likely come back under a contract agreement with the district, like, well, we're not going to terminate you. You're going to be out on unpaid leave until you complete the program, and then you'll take a test, have to come back clean, and then you probably do random testing over the next year. It's not in your policy. It would just be in the specific documentations on that case.
So is it safe to assume that if that was some precedent that was set that we're forced to now follow, and that was the case, that we would probably put that in there before somebody came back to work?
I would hope, but I can't guarantee you.
Okay, just wanted to ask. Thank you.
Any additional questions? So, if I heard correctly, I have a request from Ms. Campbell to incorporate the explicit statement of medical marijuana as an illegal substance in the policy, correct?
No. No, in the employee training materials at the beginning of the year, because, you know, as I think Dr. Fetty talked about, our new teachers go through the academy or whatever, but that they do have to follow links into the technical guide as they're going through that training, the ones who are doing it every year. And so just put it explicitly, implicit, whatever the word is, specifically stating those words in bold, bigger font, whatever, however you want to do it, but you know, on the front page, so that nobody's having to dig into it. That's not a change in policy. But I would, I actually like the recommendation of the policy change specifically about the superintendent bringing them back as a termination, so it's clear.
Okay.
Does that make sense?
Yes.
So it was two separate things, but only one of them is a policy change. The other one, I think they're actually already doing or going to do.
Yes.
Thank you.
So you are requesting a change in the policy to provide the clarity that the superintendent should bring forward a recommendation for termination in the event of illegal drug use, correct?
Right.
Okay. And then, Ms. Jenkins, did I hear correctly that you are requesting clarification that A, B, C, and D are not, or B, C, and D are not options available in the event of illegal drug use?
No, I'm definitely not saying that. I thought it was important to be having this conversation because I feel as though we aren't using, I don't understand why they're on there if we're not using them. I thought it was important for us to have a conversation and kind of dig into it. So I don't know. I don't know what to do with it there. I don't have a recommendation there. But what I do have a recommendation for is if we're going to say it's not allowed and we're going to say that it's clearly stated, then it needs to be clearly stated. Anywhere that it mentions marijuana should also say, including medical marijuana.
Ms. McDougall, you were requesting, Mike?
Yeah, I guess the A, B, C, and D for me means that it's for a legal, alcohol's legal. Over pills, some of the pills are legal that people use. So as an abuse of that, so do we need to get down that deep to say that A, B, C, D are not available for are not options for anyone that's using an illegal substance? Do we want to just get that clear? Or Mr. Gibbs, what do you think?
I think your policy's fine with the options there for the board. My recommendation was more to protect the superintendent from having to decide the board's plan here. All right, there's a lot at stake. All right, you could lose the ability to check that box on all your federal grants. The risk factors that Mark went over with negligence and everything on there, that should be a board decision, not necessarily a superintendent. There's a lot of weight and pressure put on a superintendent here, like, well, what's my recommendation going to be to the board? So it's really to protect that position from, so their response can be, I have to take it to the board per policy as a termination. All right, I'm happy if there's mitigating circumstances to recommend, the board consider lesser discipline. But those options that are on there would then fall to the board to decide how it wants to handle its drug-free workplace policy. Is it willing to lower that standard from termination and take on those risks and consequences with that? It really should be a board decision, in my opinion. So I think your options are fine where they are if you're explicitly going to state that any illegal drug test that comes back positive is going to be a recommendation to the board of termination, and the board will really make the decision as to whether it's willing to take a lesser approach.
And Mr. Gibbs, do you feel like that needs to be stated in the policy or in the technical guide, which is administrative?
It can be added, I think, to the policy, just so it's in the policy. They're both a part of the policy. I mean, the technical guide is incorporated into your 2-paragraph policy so that it is a part of the policy.
So does amending the technical guide require the policy amendment process?
Yeah, it's incorporated, yeah.
Okay, so it's all part of that same thing. Okay. So in looking at that, we have on number 1, any job applicant found to test positive for illegal drugs or abuse of legal drugs will not be considered for employment.
Right.
But then we say under board employees, any board employee found to test positive for illegal drugs or abuse of legal drugs will be immediately subject to disciplinary procedures. So we need to separate that out between illegal drugs and.
Well, I mean, you could just if you stick it in the policy, I think your policy, it's only like 2 paragraphs. So if you added a 3rd paragraph that it's the expectation of the board that positive tests for illegal substances will be a recommendation of termination to the board, I think you're covered. And then you can get into the technical guide for the board's options. The technical guide, it all says the school board may consider these disciplinary actions. It's all on the school board, not the superintendent. So if you were applying the technical guide true to its wording, it would all be the board's decision anyways.
Okay, so is there any board member that has concerns with the explicit statement of medical marijuana being an illegal substance in the training materials and where it is mentioned in the technical guide. Is that your request, Ms. Jenkins? For the technical guide as well?
Yeah.
Does anyone have concern with that? Okay. You have something after that?
Yeah, I
Okay.
have a follow-up.
My only thought is perhaps instead of stating medical marijuana, we state any form of medical marijuana, or it's, you guys can wordsmith it in legalese, but like that would include the CBD oil, which would have the THC, and you know what I mean, just to make
Right.
it clear. If we're going to put in the effort to clarify, I think that limiting ourselves to medical marijuana, defining medical marijuana as illegal, because then like what if they change it to recreational marijuana next year? Then we have to change the policy again to say including recreational marijuana, like, so do you,
That's fine. I mean, if we're going to
Okay.
amend, we can amend however you want.
okay. Are you guys good with that? Any form of marijuana, or it's
Medical marijuana in all its forms.
something along those lines, yeah, so that we're covered? Are you guys good with that? Anyone have concerns? Okay. And we've already mentioned that we are in the training materials, we're already going to highlight that, right, so that everyone's aware of it. Mr. Susan, you indicated that you had something that you wanted to,
Yeah, so here's, when I look at this, there's a philosophical difference of, we have individuals who are, you know, if it is not going to hurt our drug-free workplace, and it gives us an option to give the, you know, going into drug rehab as an option, I think that if we look at who we are as an organization, if we are going to be rehabilitating our people to do better, or if we are going to just axe them out, is two different things. So like when you look at the determination in E of 3124, it reads that an employee who is injured on the job and requires medical attention should be required to submit a drug screening when he reports to the medical facility for treatment. Refusal to submit the drug screening is considered a positive test. Okay, we went through that. We've got all that. It may result in forfeiture of compensation. It would be grounds for immediate dismissal. So will be grounds for immediate dismissal. So it's saying that if you test positive, that it may result in forfeiting workers' comp benefits and will be grounds. I would like to change the will to may, to give us the opportunity to allow them who test positive to go into drug rehab. That's all. And then if they have a positive drug test coming out, then they can come back and teach inside of our schools. I don't believe that individuals that test positive for drugs are literally going to be drug addicts the rest of their lives. And everything that we have inside of our country's research over the last 50 years has shown that there's an opportunity to have individuals change their course through rehab. And that's all. It just gives us the option to not immediately dismiss every single person that tests positive. So just want to give them an opportunity.
Belford, could I ask Mr. Gibbs a question?
of course.
In your research with all the school districts that you've contacted across the country, have you seen any school district do anything like what Mr. Susan just said?
I didn't get into how they're treating refusal to test or anything. All my conversation was what happens when someone tests positive for marijuana and they produce whatever medical marijuana card that state has authorized, and everyone had said, we terminate. Every district that they were aware of in their state said they terminate, even where it's recreational, like Colorado, and I think Michigan's attorney said that they had just gone recreational as well, and they're still terminating. And then Oregon, of course, he told me they've decriminalized all their drugs pretty much in Oregon.
Can I ask a follow-up question? So it's been said a couple of times that, so if we use those other options, A, B, C, D, that there's an increased risk to the district, but I just don't really understand the increased risk. If there is some disciplinary action and this person has to pass a drug test before they come back to the district, I don't know where that risk is. Oh, can you explain that to me?
I don't know that there was an increased risk there. The risk of being on medical marijuana is there. If they're coming back clean and you discipline them and they have to return clean, as long as they're clean, I think you're okay. If after their 12-month testing period, they resume their use of medical marijuana or whatever they were taking or their alcohol and nobody's catching it, and it comes out like, oh, wait, they went to rehab, they're going to use that against you, and they're going to say you should have known, you should have had better monitoring of this person, and those are risks looking forward. We can't say you're going to undergo random tests for the rest of your career with the district. So we're limited in what we can do from that perspective. So if they're coming back after we know they had a problem and their 12 months is over, they've stayed clean for that 12 months, and it's something tragic happens, we're going to get sued, and they're going to find out, oh wait, they were sent to rehab and you didn't terminate them. And those are going to be the questions that play out in front of a jury in a courtroom.
Right. So again, I feel like we create every single hypothetical situation we possibly can, but that could happen with any employee, essentially.
Well, if we didn't know, if we have an employee on medical marijuana, we don't know, for instance, and we've never known, and something tragic happens, we had no idea. That's going to be, and it's like, okay, you legitimately didn't know.
But the school district can still get sued for whatever incident
We'll get
took
sued,
place.
but it's defensible. That is, we didn't know they were on that. If we had known, this is what we've done historically, and it's termination right now. We've always terminated these employees for any illegal drug use. If we catch them, they're terminated, and that's been the line that's held. So that's the defense, is had we known. The risk you run is like you knew now, once they come back and if they relapse, it's like they're going to throw stats at a jury. They're going to say, this is the percentage of people on this drug that relapse. This is the percentage. So the board should have known that, whatever that percent is going to relapse. They should have foreseen that this was going to be a likelihood in this situation. And if something tragic happens, it should have been in their analysis of what they were going to do, that they should have been considering as far as in the future, should something happen.
So if a child is injured on a playground and the parent sues the school district, we're okay if we say we didn't know that teacher was under the influence.
You're going to get sued, like I
Right.
said, but it might not
It's
be
not going
as
to change
bad.
the outcome of the lawsuit.
It might change the magnitude, right? You could be like, within your cap of damages versus you're going to Tallahassee on a claims bill for millions of dollars. Right? That's going to be the difference.
You can insulate the district by saying we had no knowledge. You're still going to get a lawsuit from it, but the amount that the district might be responsible for is going to be a lot less by saying we had no knowledge of it. If we have knowledge of it and they're working for us with that knowledge, we have to defend them. Currently under Florida law, if somebody is doing something that puts kids in jeopardy, such as taking drugs, and that was the result of the injury, we can exclude a defense on them. If we have knowledge of it, we have to defend them as if they're employed with our permission. So that's why it's much better to be able to say, we had no knowledge, we're excluding them, they're on their own from a defense perspective, if that makes sense.
So if someone goes to rehab, they go through their drug testing, they're clean, we can't say we have no knowledge of them using it anymore. I mean, doesn't that technically clear up that if we followed up with this person?
It would be up to the judge as to what's going to be allowable and what the evidence in that case is going to be, whether the plaintiff's attorney is going to be able to get in front of the jury with that information. But I'm sure that they're going to do everything they can to present the history of the use and the district's knowledge of that history. But that's just the way they're going to spin it.
Mr. Susan?
Thank you. So here's a question is that there's two pieces that I wanted to, now that I'm putting my head around this thing. So now, in the event that we have a student that has a discipline issue, has a drug issue, has anything else, we send them to ALC and we allow them to come back. And in the individual, if it's a kid that is violent towards one of our other children or one of our students or one of our teachers, if they go away and then they come back and then they do the same act, we had prior knowledge, can we be under the suit? Does that make sense to you?
Clearly, past history comes into those lawsuits.
Okay.
So they do get their discipline records in a typical lawsuit, and they try and say, what additional steps did you put in place to avoid this child who has a discipline history of doing something to other students that could mitigate your circumstances? That's always part of what a jury question will be.
And the reason I brought that up is because I know it's a little bit of apples and oranges, but if we're going to do stuff for our students and our children that we stand on, then I feel like we should also offer those same opportunities in the same realm to our employees. So there's another question that I had. That was just the first one, but the second one is we are afraid that if an individual tests positive for a drug and then we allow them to go to rehab, that they're going to, and then they come back, that the same instance happens, that we're put at risk. But what happens if they come back after the 12 months or the small suspension and then they get caught again? We're in the same conundrum. So right now, as an employee, if I test positive for drugs, I am sent away and I go off, right? And then I'm allowed to come back 12 months later. I'm allowed to be employed by the district. What is the difference between us sending them to rehab and allowing them to come back 12 months later?
It's still going to be your risk,
But we are assuming the risk of the 12 months already.
assuming they get through the hiring process. We would still know, like, hey, this person's had a problem. So if somebody's making that decision as far from the perspective of, do we want this risk brought back into our district? Right? If you're disciplining them, you are saying, and you're just suspending them, they now have a right to return. You aren't making the decision. That's the board. That's why I said the superintendent the recommendation should be termination, and it should be on the board. The
Sure.
board
So-
is then weighing the risk of that person coming back with a lesser discipline.
So my argument is that we currently allow teachers, and we have many instances, that they have been tested positive for drugs to come back 12 months later. They are currently employed inside of our school district. We have assumed the risk of those individuals. We have employed them. We have prior knowledge of it. But now we are saying that you can't go through rehab because we're going to assume the risk in the event that they do. And I think that on top of the other issue with the students, I think we're assuming the risk already. I would like to have the opportunity to give the superintendent the opportunity to not fire them and give them the opportunity to go through rehab. That's my only thing. I'm okay with saying marijuana is bad. I'm okay with saying that we need to go through it because it's the federal. But giving them the option, I think, is the humanity and humane way to do it.
Ms. Campbell, I've got Ms. McDougall, and then I'm coming to you, okay?
Yeah.
Ms. McDougall?
As I understand it, I don't know the history of the policy when we have A, B, C, D. It was before my time. But there are some medications that there is no rehab for. There just isn't. And there are many drugs that have a high incidence of relapse over and over again. And my understanding that I get nervous when we mandate someone to rehab. I would think that if somebody was clear and they wanted to get sober, let's say, or drug-free, that they would say, I have a problem, I'm going to go into rehab. We use the EAP, but they do that on their own, that we don't mandate it. Dr. Theddy, have we ever mandated treatment for any of our staff, and has it worked?
I don't have that data in front of me to be able
Okay.
to tell you.
I didn't even think to ask for that, I'm so sorry. Because there are certain drugs that rehab is not available. Marijuana is one of them. Heroin is a long, drawn-out rehab with methadone, transitioning down to methadone. So I like where you're going, Mr. Sisson, but I really don't want to be the person that says, as the board, I want you to go to rehab, and then we can see if you can get your job back. Right now, we have people are terminated for drug use, and if my understanding is they can come back a year from when they were terminated if they are clean, and that's the end of that. We don't do random drug checks if they come back clean, if they come back to us, do we?
If they make it through the hiring process, which includes a drug test, they could come back. We don't submit them, they do not submit to randoms in that case. They would if there was a reasonable suspicion case or some post-accident.
Okay, thank you.
And I'll just throw out for just since you brought up mandating, if you mandate, the district may be on the hook for the cost of
Right.
the rehab.
Which
Can I
is where
follow
was-
that? Because my motion was not to mandate
Yeah.
anything at all. I don't know why we got down the mandate level. Out of respect, I was going to let it run, but I didn't say mandate. It just gives the option that the superintendent can say, in the event that you want to stay and you want to work, you have this option that you can go to rehab. And in most cases, like you said, heroin, others, it might be just as good to go, or just as long to go into as making them come back 12 months. My concern is our current policy allows a person to just leave, pass a drug test, and come back. I think that the true essence of getting better is to go through a program. And that's why I said that that's an option that we should be able to give them, not mandated. And is that right? We don't have marijuana rehab?
We do. They do.
Ms. Campbell?
I was fascinated what drugs
So-
don't have rehab.
So that's actually where I was going next is with the financial piece of it, because as a recommendation, even if we made it in some way, not mandated, but recommended, whatever, are we liable for, or are we responsible for paying for it? Or even if we're not responsible for paying for it, then we're trying to build in what program is good enough? Did you do a 30-day, a 90-day? Did you do, whatever? And the truth is, like as you and Ms. Jenkins have both pointed out, Mr. Susan, is that people can come back right now in a year and pass a drug test, but there's no guarantee of a position. So to me, the difference between you go to rehab and come back in a year, or you get terminated and come back in a year, is one, we have to decide as a district, or their employer, whoever's bringing them in, whether it's HR or a principal or whoever, are we going to take you back in? Do we have a job still for you? And then two, obviously having a termination on your record is not lovely, but I just don't, and those are, I'm not saying those are small differences, but I would just, when you talk about the difference between our students and employees, and I'm there with you, I want us to have compassion, but I would point you out to the page that we had talked about after the student policy, which is there's a huge difference between our students and our employees who are responsible for the safety of those students. And I think we have the opportunity, we want to have compassion, point some people in the right direction of rehab, but, I don't think we belong in that space.
Can I please respond?
May I follow up?
So
as
as
well?
far as a financial piece, there was no mandate, so there is no financial piece. If we can get away from the financial piece and just, if we do not make it mandated and you allow them to do it, we are not talking about paying for them to do it. Absolutely no guarantee of a position. There's no guarantee of a position the following year. But what I would do is I would look at every time we fired somebody in this district for what has happened inside that classroom is that we put in a full-time sub. The education levels significantly dropped. So the idea that we would rather a full-time teacher who was in that position possibly come back after rehab would be not have a job. The past has shown us that there's a full-time sub in there that doesn't have the same qualifications in most cases as who was in there before. The last piece is I understand 100% the difference between the students and the employees. I do. You are 100% right. I'm talking about the compassion for our employees. We have compassion for our students. We tell them that we care about them and we want them back. By not having this piece as far as giving them rehab, we take out a huge piece that we already afford the compassion to our our students, that's all. And this still gives you, if somebody is inebriated, it still gives you the opportunity to fire them. It gives you every piece. It just gives them the back-end opportunity to send them to rehab. So, but there's no mandate. I just wanted to say that.
Ms. Jenkins?
Thank you.
Yeah, two things. I just have to say, I find it ironic that we keep harping on how our teachers are different than our students because they are in charge of supervising our kids when the proficiency of supervision is what caused this recent staff member to spark this conversation. And so when we talk about rehab for marijuana, there is rehab for marijuana, whether or not, we want to argue if we think it's effective or whatever. I mean, it is out there. But when it comes to this specific conversation, rehab doesn't have to necessarily mean they're going into a facility, right? Rehab would mean they are rehabilitating. They're going to choose a different plan for themselves, a different medical plan. They're going to speak with their medical professional and decide a new plan for their life if they choose. So again, I just want to reiterate as well, I'm not on a mandatory either, just like Mr. Susan. It's just laying a choice out there for that person to make for themselves and for their life. And it doesn't mean that they're gonna choose that option. They might choose the other one, and then the only other option is termination. But that's on the individual. So, right.
So are we paying, can I ask, are we going to pay for them to be on our payroll while they're going through whatever rehab they choose, if they choose it? I'm asking the question.
Since it's my motion or my idea, I'll further that. Those are all discussion points afterwards. If we wanted to you can or you cannot. We can choose as a group, if you wanted to move forward, to not do it. You can move forward with saying we may, which allows them to go to rehab, and then we may decide that while they're in rehab, they don't deserve it. They don't deserve to have a payroll. They're the ones that tested positive and everything else. Those are all discussion points. My idea would be that they do not receive payroll while they're not working. If you were to ask me, Ms. McDougall, I would never ask the school district to cover the cost of a teacher while they tested positive for drugs and then went to rehab. So if that's your question, that would not be my intent.
Well, my understanding is don't we already have that choice for our staff? That we have C, D, and E, and one is to go into treatment.
That's a great point, Ms. McDougall. I am looking directly at the policy that says those exact words and will be grounds for immediate dismissal. If we change it to may, that means that if you are in this situation, you may go to those options. If we do not put may in there, it does not give us those options. That's all. And it still doesn't mean that Dr. Mullins is going to say to everybody, yeah, you can go to rehab, you can go to rehab. He is still going to, and I am very confident of this, bring forward to the board the termination of many of our employees. I would just like to have the option to use those said parts of the policy.
Mr. Gibbs, the part that Mr. Susan is referencing on E, an injury on the job which requires medical attention, an employee who's injured, refusal to submit to the drug screening is considered a positive test. It may result in forfeiting workers' compensation benefits and will be grounds for immediate dismissal. Does that require immediate dismissal, or does that say that you have grounds to bring forward the recommendation for dismissal?
What section are you in?
It's in the very first part. It's A, B, C, D, E, the first lettered section after the opening paragraph on the technical guide.
So I think
Yeah,
that
no,
statement is referring to the sentence prior to it, refusal of the drug
Right,
test.
yeah, I think it's, yeah, the refusal would be grounds for bringing, and I think it's still permissive. I mean, the superintendent would have to make a recommendation as it's written. It will be grounds for discipline or immediate dismissal. So they're just letting you know if you refuse, you may be immediately dismissed.
And
on that one.
That's just in reference to the
The
refusal
refusal.
of the blood, of the drug test being considered positive, correct?
Right, yes.
So down where we have been talking about in the technical guide, down at the failure to pass drug screening under the A, B, C, and D.
Right, that's the technical guide.
Yeah, the technical guide on it. Employees who test positive for illegal drugs and/or abuse of legal drugs may be suspended, terminated, required to submit. Is that not stating that we have options there?
Right, that's what I was saying earlier, was it's the board's discretion anyways, but my recommendation is simply for the expectation of the board to be expressed that they want the superintendent to bring it to the board for the board to make that decision, rather than if the superintendent were to say, I'm going to reduce the discipline from termination to a suspension and testing afterwards. If there's no dispute with that discipline, the board doesn't get the opportunity to weigh in. My recommendation is it should be a board decision, and the recommendation should be for the board to make that decision by expecting those recommendations to be termination, and the board will make the decision whether to lower the discipline imposed. That's what my recommendation is for.
And can you fit that into?
Right, and that's what
That
I was just saying.
section,
If we just fix the main policy with an added paragraph of it's the expectation of the board that any illegal or positive illegal drug test comes as a recommendation for termination for the board's decision, I think it fixes it all. If you leave the technical guide alone, the board still has those options.
Okay. Dr. Thetty, does our contract allow us to put employees on unpaid administrative leave?
It would be, no, it depends on the employee, it depends on the professional services, AC. Statute actually governs whether they're on unpaid leave or paid leave, and you have to make that decision as a board. Now, if a person chooses to be on a personal not paid leave, that's the individual. But for us to make that decision, it has to come before you.
And statute guides who can and cannot, who is allowed to be placed on paid leave versus unpaid leave?
The statute, and I don't have the statute in front of me, so I can't quote exactly what it's saying, but it speaks to putting somebody on paid leave if they're under investigation for something, whatever it might be.
Okay. And did you want to provide additional input on the current discussion? Was there anything else that you wanted to
I
share?
wanted clarity, but I think we got the clarity. I was confused by the conversation under E because I was believing it pointed to the refusal to take the test, but I've gotten my clarity, so thank you.
Okay, absolutely.
Ms. Belford, I've got one other,
Ms. Campbell.
Can I follow up on my thread?
it'll be really quick. So currently, these kind of terminations, or any kind of termination, only comes to the board for votes on the agenda for, well, not always, but teachers. We have on our consent agenda terminations, like we have one tonight for other employees. Would that mean that in the future, we would have that kind of, it would come to us differently for our employees that are not?
Not necessarily. It would still be the same process.
Because we're still voting on it.
The expectation would be expressed in policy that if someone tests positive for an illegal drug under federal or state law,
Okay.
the superintendent recommendation is going to be termination.
So it doesn't change how it comes to us?
That takes away, it protects your superintendent, because if somebody's like pushing, oh, you need to really do this for this employee, it's going to be, I'm sorry, the policy is termination. I'm happy, and he can meet, like I said, he can meet with whoever, and they can explain what happened and say this is what it is, and it was an accident, or I grabbed the wrong bottle, or whatever the situation was. Then he can bring that to the board and say, hey, I believe there's mitigating circumstances that the board should consider in possibly considering reducing the discipline here. But per policy, the recommendation is termination. And that would trigger the board discussion on what the board wanted to do. And then the board would weigh all those risks. It would be on the board and not necessarily the superintendent's shoulders.
Mr. Susan?
So let me ask you this. I just want to be clear. If an individual in our organization tests positive for drugs, the superintendent has the opportunity, if they ask, to send them to rehab. Is that correct?
Right now, the superintendent can lower the discipline that he's recommending to the board. If it's not contested and they're going to go with it, then the board would never get involved.
Okay. The back piece is that I was going to ask, I'm confused about something. We are now taking the risk and liability away from the superintendent and the school district and putting that risk and liability onto the school board. So in the event, is this open up the school board for liability and lawsuits based upon the follow-up to what you were just saying?
No, you've already got it. The liability is always on the school board. The school board gets sued. The superintendent doesn't.
And then if the school board is sued, we represent the school district. The school district steps in, defends us, and any of those claims bills are paid out by the school districts, not the school board.
Well, the school board is the district. There's only one legal entity, the school board of Brevard County, Florida. That's the legal entity for contracts and for suing and being sued, is the school board of Brevard County.
It gives us more control, not less.
I understand. I'm just trying to look at liability. It just kind of
Right.
freaks me out. That's all.
But yeah, I mean, the same liability is there. It's just the board is the one making the decision as far as what the impact to the district will be.
By closing that door of what you just said, it does not give any legal opportunity for the superintendent to offer them to go to rehab and everything else, right?
He can come to the board and say, I would recommend you consider
Yeah, but that's
mitigating
getting out-
circumstances and lessen the discipline.
But superintendents would never do that. They literally, I mean, I know him, he's not going to do that. So what I'm hearing you say is that we have a situation where we have an individual that was like, hey, I would like the opportunity to possibly go to rehab or do all that stuff, but now we're going to completely constrict that, say, give him the opportunity to just terminate or not, give us the opportunity to talk about it, but then what's going to happen is, because I know you, Paul, you're going to say, we shouldn't go against policy, because that keeps coming up. So if
Policy's there. I'm not saying don't go, your policy is what it is. I said you need to weigh and consider the precedent setting factor. If you want to do this, whatever you do for one is you got to do for everyone. So when you were getting into, we're not going to do this person, that's going to open you up for discrimination. So you have to be consistent. If you are going to allow an positive illegal drug test for one drug, you're going to open the door for the argument of, well, you allowed, that drug user to go to rehab. You can't fire me. I've been caught for illegal drug use. I need to be offered rehab. If you start saying, well, no, you're not a good teacher, or you've been written up 4 times, so we're going to terminate you, you're going to get into discrimination.
Yeah.
So that's what I say you need to weigh. I'm fine. If you want to say, hey, we're going to draw that line there, that's where you draw the line, and you need to be consistent with it. That would be my advice to you.
I just think we're going to be set in a situation where we're going to be going, are you saying that our policies would still remain in place, that the superintendent would move to terminate, but then we would then be given the opportunities for A, B, C, D to send them to rehab, to do all those things?
You already have that.
But in your case, you're going to say that you shouldn't go there because of the discrimination policy that may exist.
I don't say you shouldn't. I say you need to be aware that you're setting the precedent and drawing the line
There
here.
it is.
So for every future case, this is going to be your line. You can't move the line. You can't say, we're doing it here on this one, and it's going to be over there on the next one, and we're going to back it up to here on the next one after that. Where you draw the line, you got to draw the line. You got to hold it.
And I would just remind the board that in many decisions inside of this district, we are not agnostic to, or we are agnostic. We are not make a decision straight all the time, whether that's employees, whether that's students, whether that's anything. So we don't. So just, that's all. I know I'm driving you crazy. I'll leave it alone.
All right, so does anyone wish to make any additional requests? So it sounds like, Mr. Gibbs, you're going to be bringing back to us a recommendation for an amendment to the policy and technical guide at a further meeting, correct?
Yep.
Are you?
We'll put that on the rule amendment process.
Okay, and do you need any clarity on the requested changes at this point, or?
No, I think we've got it.
Okay.
All right. Want
Does
to
anyone
get to
else
the next
have-
slide? And just as a parting note, this is the website for the Office of Medical Marijuana in the state, if there was any doubt left as to its current status. So it states on there specifically, it is illegal under federal law.
Can I
Thank you, Mr. Gibbs.
I have a question.
Ms. Jenkins?
Am I on? I can't see. There we go. I'm a little confused about the recommended change, taking the burden off the superintendent, because I just don't understand. Technically, right now, the superintendent can choose A, B, C, and D.
Right.
Technically, right now, the superintendent can come forward with a termination, and the board can then decide to choose A, B, C, and D, correct?
Right?
So what is the benefit of changing that?
The board, all of the implications on long-term effects of anything is the board's. So if the superintendent draws the line, it's not the board drawing that line anymore. The superintendent has drawn the line. He has set the precedent. And in the future, any other superintendent would be setting the precedent. This is allowing the board to hear the facts and say where it wants to draw the line. That's going to be held, and that's going to be the expectation.
So
And
it's
in
taken-
my opinion, that's where the line, that's who should be drawing the line, is the school board. Like, what is the school board willing to accept for certain offenses?
Okay, so it's just taking the burden off of the superintendent to
Right.
to ever choose B, C, and D. That
It's
he's not
it's
the one making
insulating
that
the
choice by
superintendent.
himself.
The superintendent can simply say, the expectation on me is to recommend termination. And like I said, he can still meet, whoever's in there in the future can meet, and he can come to the board and say, I believe there's good mitigating circumstances the board should consider in this case.
I don't like it. I'll fight it when we get to the next step, but there's 3 that want it. We've been on this forever.
Anything else for the good of the order? Going once, going twice, hearing none, this meeting is adjourned.